Hello, good morning, everyone. We are all welcome to this Saturday's session, starting with orthopedic assessment. Our facilitator will soon join us. Please give us some few minutes to be with us shortly. Thank you all.
Good morning, everybody. Good morning.
Good morning, sir.
Good
Yes,
morning.
I'm sorry, I'm
Good
joining a
morning,
bit
Prof.
late.
Welcome.
Sir.
I waited for the link only for me to go off my office, and then I was held back. So I just came into the office now, so we can start. Okay, I think let me. Dr. Jibril somebody, do I need to introduce myself? I think we have had.
No, I think it's a good thing, Prof, so that people that don't know you can know you better.
Okay, I hope I'm visible. Can you see my video is on?
Yes.
Right. Good morning, colleagues. I'm Bashir Bello, a professor of orthopedics and sports physiotherapy from Bayero University, Kano. I'm also an extraordinary professor at the Lifestyle Disease Research Institute at Northwest University in South Africa. My primary research interest is on musculoskeletal disorders, specifically on low back pain. So I'm glad I'll be having opportunity and privilege to speak with you about current practices in managing low back pain. Without much discussion or introduction, I think if this is good enough, the Dr. Samani as the host, can I start, or if you have one or few comments to make before we make progress? Yes, please.
Prof, we can start. No problem. No comment.
Thank you.
Yes.
I'm just going to switch off my video to allow a free flow of the workspace. I'm trying to share my slide. Okay. Yes, I think this was the slide. Is this, can you see my slide?
Yes, we can
Yes,
see
sir.
it.
Once again, good morning, colleagues. I today will be having the program or workshop on assessment and management of non-specific low back pain. But we are not going to be doing the management specifically, but we want to see what we want to talk about the outcome measures that we're expected to know that these are the essential outcome measures that we should use to evaluate our patient with non-specific low back pain. So as a way of introduction, I said the workshop objectives include we should, number one, understand the burden and the nature of non-specific low back pain. Today we'll be learning a structured assessment approach, because if you don't assess your patient properly, you'll not be able to give the utmost and best treatment. Number three, I said we also apply evidence-based treatment strategies. What should we be doing now in treating patients with low back pain? Then we'll talk about the standardized outcome measures that should be used in the management and assessment of low back pain. And lastly, we'll talk about how to promote holistic and a patient-centered care. And this way, I mean self-management programs. So we'll be diving into the work as we go. The way of introduction, I say low back pain is one of the most common causes for people to seek medical care, both in primary and emergency setting. What I mean by that is among most of the musculoskeletal disorders, low back pain is one of the most common reasons people come to the hospital. It is estimated that over $500 million are being spent annually in managing low back pain. That's huge. Over 500 billion. You can imagine that. I said low back pain is the most common reason why people go for absenteeism, and of course why there is a loss of manpower to productivity. So people don't come to work, people are not able to work when they get into low back pain. I said there is a broad range of potential causes for low back pain. A lot of things can lead to low back pain. And these causes can differ depending on the patient population. But the most commonly thing that we see is the cause for low back pain is mechanical or non-specific. When we say non-specific or mechanical, what does it mean? It means there is no any specific pathology that is attributable to the low back pain. Hence, physiotherapy assessment aim to screen, number one, to identify that this back problem is not as a result of serious spinal conditions. When we talk about serious spinal condition, we're talking about maybe like tuberculosis, that is the Pott's disease. It's not trauma to the back. It's not cancer-related back pain. So all these are serious spinal conditions. When your spine is infected, it's a serious spinal condition and requires emergency treatment, medical treatment. When we do physiotherapy assessment, we try to rule out that this problem is not a serious spinal condition. We also do that. Our assessment is to help us identify impairment that may have contributed to the onset of that pain. So it is not a cause, but rather we're trying to identify what are those things that will have led to more pain. I said we assess our patient also to identify factors that may likely increase, the likelihood of the person developing persistent or recurrent pain, that is recurrent low back pain. Let's see the epidemiology and prevalence of low back pain. Do we think low back pain is more common among the rich people or the poor people? Where do you think you're going to have more low back pain?
Rich people.
Poor people.
Poor people? I'm not getting you. Do you think the back pain should be more common among the rich or the poor? Where do you think that lie?
Both.
Good morning.
Both.
For you, is both. Somebody told me the poor people. I wanted to ask, why do you think the poor person are likely to have back pain more?
Well,
Sorry?
the poor people will most likely take part in
Listen.
manual labor, so it can lead to their spine wearing out faster.
Okay, what about the rich people?
They mostly have sedentary lifestyle, so the weakness of muscles can cause imbalance and also cause pain.
So what it means is there is no any preferential prevalence between the rich and the poor. That's what it means. Everybody equally have back pain, okay? And that's how it is among males and females. Do you think females are likely to have back pain more than males? Yes.
I've seen it more in females, though.
Okay, in your 13, you think females have more back pain. Why? What could be responsible? What could be responsible that females have more back pain? the truth is there is no any gender preference in people with low back pain. So it just depends on how this patient comes to you. Most of the epidemiological studies have shown that there is no any significant difference between males and females when it comes to incidence and prevalence of low back pain. In general, I want us to understand that low back pain is highly prevalent in all societies, meaning both in Western or in developed, developing, and underdeveloped countries. The same is the situation. There is no difference. We all have low back pain together. Research has shown that over 80% of the population are going to have low back pain at a point in their lives. So what it means is in every 10 person, it's only 2 people are likely to go scot-free without low back pain at any point in their life. So this is something that shows that low back pain is widely spread among the population. So there's no that it means there is no any population that can be spared, of low back pain. So this prevalence is the same among those who are both active, sedentary, and those who are rich or poor, male and female. So we see it together. According to the GBD study of 2013, it is the global burden of disease. It's estimated that it is about most percentage of back pain, come from what they say it is non-specific. That is, there is no any attributable pathology. And they showed that instead of the 80% we're talking about, people are likely to have 90% of every population are likely to come up with back pain. Of course, but the back pain is not likely to be bothersome. So, but at the same time, if we don't control it, we are not likely to have, people are likely to come up with disability the more. Because the GBD said in low back pain is one of those MSKs that lead to disability most. Because if you cannot control the back pain, it will come back with persistent and recurrent back pain, which is going to cripple the patient. The same way I mentioned that age and gender variation does not really matter. Only that when you see low back pain among adolescents, it shows you that there is a likelihood of serious spinal pathology. Okay? Adolescents are not expected to come up with degeneration of their back. So when you see back pain among adolescents and children, we should quickly go in to evaluate for any serious spinal pathology. Occupational impact also have a lot to do with low back pain. Somebody mentioned to us earlier that people that engage in high labor or demand job are likely to come up with back pain. Somebody who is an engineer that carries a drilling machine and bend the back to drill, or somebody lifting heavy weights to carry some to use weight. Okay, so these are all concerns that will show you people have issues with the type of job they do and the prevalence of their back. So your type of job really impacts on the prevalence of low back pain. An office worker who sits for a long time, like a banker, somebody, a customer care service in any organization that you need to be seated for a very long time, a secretary, all these can predispose one to more common back pain than others. Somebody also mentioned to us that your physical activity level can also impact on how you develop low back pain. Yes, these are all factors. Now, socioeconomic factors can also predispose one to having more low back pain than the other. All right, we've seen that people in underprivileged communities are likely to have more low back pain. Number one, maybe due to poor knowledge of ergonomics. Number two, due to the economic facilities or infrastructures they use are not compatible with their bags. They lift heavy weight, they carry heavy load, they do so many manual tasks. This can also lead to low back pain. So the epidemiology and prevalence is almost the same everywhere. Now let's look at the classification of low back. I said back pain can be classified as either acute or chronic. Generally, we say low back pain is acute if it's between the first 2 weeks. Okay, the first 2 weeks of the first episode of a low back pain is what you call an acute low back pain. The moment it gets to the third week, it goes into what you call subacute. From 3 weeks up to 12 weeks, you call that subacute low back pain. But a back pain that goes beyond 3 months is said to be chronic low back pain. So you can see that it is the duration that is being used to classify the low back pain at this point. So you can have acute, subacute, and chronic. Now you also have what they call the mechanical and non-mechanical low back pain. I'm sorry, I don't know if the child cry is disturbing. I'm in the clinic. Can we go ahead or I change the office?
It's fine.
Okay, thank you. So we also have mechanical and non-mechanical low back pain. By mechanical, it's the same thing we're talking about, that this pain is due to what? Structural changes in the body, especially in the vertebra. Maybe due to structural changes in either the disc, the muscles, or the ligaments all supporting the back. Those structural changes can be said individual has a mechanical low back pain. The non-mechanical means is not a pain that is related to the structure, rather it's a disease pattern, say infection of the spine, or you say that there is a trauma to the spine and all that. So all these are non-mechanical. Of course, you could also classify low back pain in terms of specific or non-specific. Specific low back pain is the most or the least common percentage of low back pain. It means a low back pain that is attributable to a certain disease or pathology. That is specific low back pain. But when you say it's non-specific, which is about 90% or 95% of all low back pain, they are all non-specific. There is no any specific pathology that can be attributable to that. So this is called the non-specific low back pain. Of course, you will have both radicular low back pain and axial low back pain. The radicular back pain is when you have low back pain that also radiates to other parts of the limb, like the buttocks, the thigh, or the foot. Okay, that is radicular low back pain. We usually say low back pain with radiculopathy. Of course, there is also what you call the axial back pain, which is related to the back pain that stops only in the back. So before I move out of this classification, I don't want us to mix up the understanding that I just mentioned now, radiculopathy and radicular pain. These are two different things. I hope somebody will remind us to expatiate when we go into the presentation further. All right, we also have what you call inflammatory and non-inflammatory low back pain. So at this point, you're trying to say there is a specific cause of what is happening in that back has already led to what? Inflammation of the back. So when there is inflammation, like inflammation of the disc or the structures around the disc, all this, you call them inflammatory, and you see it at the acute stage or acute low back pain. Sometimes you can also see acute low back pain sorry, you can see inflammation or the inflammatory lower back pain in chronic low back pain, but they call it chronic low back pain with acute exacerbation. Somebody has been having low back pain for 6 months, 1 year ago. Now he now went into, maybe he fell down in the toilet, or there's something that creates an acute exacerbation. That's also going to present with inflammation. So you call it inflammatory low back pain. All the classification is meant to direct the assessment and management of the patient into a specific triad or into a specific pattern. And that's why we'll see that we keep paying attention on how to classify the back pain. The moment you get the classification correctly, your type of assessment, your type of treatment is going to guide what you're going to do eventually. Let's look at this image. I hope this image is clear enough. What I'm trying to depict here is a patient that will present to your hospital with acute low back pain. The first thing you should do is to undertake the triage process. This triage process is for you to be able to classify this patient with low back pain to fall either in any of this sub-classification we have mentioned earlier. So I said the first thing is you look at if the patient is presenting with low back pain with significant neurological deficit. Do you understand? Does it have neurological deficit in terms of cauda equina syndrome? Does it have sciatica due to symptomatic disc prolapse or central stenosis? Or does the patient present with maybe something that shows there is a spondylolisthesis? That is, there is what? A shift of the vertebra from the other. So these are issues that you call low back pain with serious spinal pathology. Because when you have cauda equina syndrome, the patient may not be able to hold their urine. Okay? So we need to understand that you have low back pain with neurological condition, and then you have low back pain with serious spinal pathology. Now, the difference is that patients with low back pain with neurological condition have been classified according to percentage not to have more than 5 to 10% of every type of low back. But those are those that come with neurological condition. Your radiculopathy, you should know, is a neurological condition. Weakness of the muscle is a neurological condition. But when you have a patient that cannot hold their urine, it's said to be what? Serious spinal pathology. So let's not mix both things up. Now you move to be sure that this patient, does he have neurological deficit or not? If he doesn't have, you also want to see, does the patient have any serious or systemic pathology? They said the serious spinal pathology are those such as malignancy, infections, or fracture. So, and these patients, they constitute not more than 1 to 2% of all type of low back pain. So it means the bulk majority that will come to you are just that they said 90% is what you call the non-specific. You are not very sure this problem that the patient is coming with, is it muscular issue? Is it disc problem? You are not sure, is it ligamentous strain of the back? You are not sure, is it the blood vessels, you call facet joint arthritis? You know, so many things could have just come and playing interconnected and interrelated together. So you cannot attribute it to a specific pathology. You call this the non-specific low back pain. And it means you have over 90% of your patients that will present with this. What we're saying here is that there is no any clear anatomical diagnosis. And of course, there is absence of red flags. I hope I'm not rushing. Can we continue? Or somebody has a question we need to clarify?
Let's continue.
Okay, thank you. So let's see some quick anatomy of the back. I've loaded here because I do not really know what we need to talk about all in terms of the anatomy of the back. But I want us to know that when we talk about low back pain, we're only trying to look at the region between the 5 lumbar vertebrae to the first 2 sacral vertebrae. So low back pain is labeled from L1 to L5, as well as S1, S2. So low back pain is said to be any pain that is located in the lower back region. Now, we should understand that the anatomy of the lower back that comprises these vertebrae are divided between each vertebra L1 and L2 by what? By intervertebral disc. The disc is expected to give the cushioning effect so that a bone doesn't rub on another bone. Now, at the embryological level, all these vertebrae are arranged in such a way they give us our lordotic spine. That is the natural curve of the back. This curve is what helps you to bear weight and stability either in standing or in sitting. So therefore, the moment you begin to see that there is a loss of lumbar lordosis, it means there is a tampering with the structure of the low back. Now, I said the intervertebral discs act as shock absorbers and allow your flexibility to go through flexion of the back or extension of the back. So these are what you do with those flexible structures. The vertebral body is very thick at that low back, and that is where it bears the weight of the body through the back. The vertebral body is what carries the body weight. And of course, it is the structure that gives origin and insertion to all muscles that connect the back. Apart from the facet, the vertebral body, you also have the facet joints. These joints are those appendages between the lamina and the pedicles. I don't know, I don't have a pointer. I will have been pointing those sides, but I believe we all know those common anatomy. So the facet joint, which is also a synovial joint, don't forget, and that's why sometimes arthritis of that joint can be the cause of your lower back. So it would have been all this that we always pay attention. Your facet joint connects one pedicle up and the lower lamina to form a synovial joint. This synovial joint is made up of capsule, synovial membrane, and so on and so forth. So it can easily get arthritic. So you can also have arthritis of this joint because it's on constant movement. The facet joint is what provides the fulcrum, for the movement to take place in our spine. Apart from our facet joint, we also have our spinal nerves. The spinal nerve is what forms the lumbar plexus. If you look at it here between L1 to L5, you see the yellow stripe that are all the nerve roots coming out. And they are there to supply both sensory and motor function to the lower limbs. And this is the reason why if any nerve gets entrapped, get inflamed around any of this region, it transmits the symptoms to the lower limb. So we must understand how these nerves come out from each of the intervertebral foramen. Now, apart from the spinal nerves, we also have the muscles, which give muscular support to the vertebra. I said the lumbar spine is supported by various muscles which help maintain stability and movement. It's a very common understanding that the moment your muscles are not functional, because according to Height in 1996, this researcher found that the first episode of low back pain any person will have is going to present with is going to present with hibernation of those muscles. It means the muscles will not be contracting. The muscles will all have what they call, even when they don't have symptoms, they will go on hibernation, so they are not working. And the moment your muscles are not working, it will lead to instability of the back. Don't forget that the stability of the back is made up of 3 components: the muscular component, the vertebra itself, and of course, the other structures below. So the moment one component, which are the muscles, are not functional, it creates instability, which is the reason why we see we have to do some core stabilization exercises. And now, with all these background anatomy are very important in making a decision on how to make your diagnosis or assessment eventually. Because we should not give one shoe that fits all. There is no one shoe that fits all with people with low back pain. You're going to be wasting so much of your time if you continue to do stabilization exercise for a patient who doesn't need it. So it means you must learn how to assess the function of all these structures we are talking about. Of course, you have the ligamental support. This also provides additional stability. Don't forget, a ligament connects a ligament connects, we say, bone to a bone, okay? So since it's a bone-to-bone connectivity, we will expect that the patient have more stabilization. So it means when the ligament or muscles are affected, the first thing you will identify, there's going to be instability of the spine. Now let's make progress. Let's look at the functional anatomy of the spine. I said the spine generally is what creates what we call the core stability. I don't know if this is big enough, if you can see from here. Can we see it now? I said it gives us our core stability. That is, we must know that the back anatomy plays a critical role in stabilization of our back. Okay? Now, if this is not there, it means our posture, okay, and our spine is going to be affected. The moment the posture of an individual is affected in the back, it means there's going to be high risk of developing more back problems. Because if your core is not strong enough, you won't be able to prevent the interacting forces. Don't forget, whenever you are standing or walking or sitting, there are three forces that are acting on that spine. One is the gravitational force coming from up, you know. The other one is what you call the external forces, the external environmental forces hitting you. And the third one is ground reaction force. So these three forces act together to stabilize you. So if the muscles are not good enough, there's going to that we're going to have issues because the back will be forced. Of course, we know that the back, one of the action of the back, also the lower back, is for our range of motion. And then the moment you have a good spine, your lower back helps you to move the spine into different range. A back that is functional will be able to go into both flexion, extension, lateral flexion, rotation. That is all this activity that facilitate our day-to-day activity. Imagine you want to reach out on top of a cardboard, or you want to reach out, you want to write on a board. You know, you don't just use only the shoulder, you use your back. Okay, if the back is not functional well, the moment you reach out to write on the board, you find out that the individual will not be able to do that. And so many activities, sometimes even just entering your car or coming out of the car. All these are issues that we may not we've been paying attention to. Back also helps us with weight bearing. Our low back bears more significant portion of our body weight. Most of the body weight is on our spine. And that is the reason why the moment a patient presents with a problem in the back, if the back is not taking more of our body weight, it begins to distribute it. The patient will begin to have problem with either the hip, the pelvis, or the knee or ankle. You know, the weight is being distributed to different connectivity in the body, and there you have more problem than what the patient is presenting. So the back is very, very important in distributing our weight effectively in standing, sitting, or movement. The back also helps us to do what they call the shock absorption aspect. The back acts as a shock absorber by cushioning the impact of forces that I mentioned earlier in walking, running, or jumping. So if there is no those intervertebral discs functioning, it means most of the forces that are hitting us can collapse the whole back. And this is the reason why the moment you begin to have problem with your disc, your shock absorber begin to get reduced, and then more trouble will hit the back easily. The musculoskeletal supports involve both the erector spinae, that is the large muscle of the back, the transversus abdominis, which are also the part of the core muscles, that stabilizes the back, and the oblique all provide stability, and then they assist in movement. There are those muscles, especially the what you call the multifidus muscle. These multifidus muscles are not involved in the contraction or movement, but they are there to stabilize the spine, while all the erector spinae and the transverse abdominis do their movement. So these are very important muscles that we must also get to know about them. And lastly, another anatomy of the back we need to put at the back of our mind is the connectivity between the pelvis and the hip. You can see they are closely interrelated and interconnected. Just yesterday evening, a young boy of 4 years was brought into my clinic that the baby, since when they realized he was walking at age 1.5 or close to 2, the boy is limping on the right leg. Now, the orthopedic surgeon asked them to do an MRI of the lumbar spine. Now, because the MRI did not show anything, they did not bother to check this pelvic and hip connection. And the moment the patient came and I asked just for a plain X-ray of the pelvis and both hips, it shows that one of the hip is already collapsing, And I was thinking it could likely be to an avascular necrosis, early AVN. I quickly sent the patient for genotypic matching. Let's see what's the genotype and all that. So we're expecting the result today, and before we know where to take up from there. So we must understand that the lower back is closely connected to the pelvis and hip, and it means if the lower back is having problem, the hip or pelvis can also have problem. Or if the hip and lower back is having problem, if the hip and pelvis is having a problem, it could also affect the lower back. So the entire lower body's movement and stability depends on the synchronous activity of both the hips, the pelvis, and the lower back for you to have good movement. So these are some functional anatomy we need to remind ourselves. This takes us to the biomechanics of the lumbar spine. What are those mechanical activities that occur in our lumbar spine? Of course, it's not hidden. We have mentioned it before. The first thing is that it gives us our movement ability. So the flexibility and mobility that we do in our body is coming from the lumbar spine, okay? And that's why we talk about what is the relationship between the cervical region and the lumbar region in terms of biomechanics. We say most times the cervical region is huge with movement, while the lumbar region is restricted or is reduced with movement. It means this lumbar side gives us more stability to carry our body weight, while the next move very well. Now, in trying to carry our body weight, the lumbar side is likely to get degenerated faster than the upper part because of the mobility and flexibility that is there, and because of the strength of weight to be bearing. So all these are mechanisms we should know. Of course, we talk about the shock absorption, which is involved in the disc. All these are those activities we need to know. If you jump up and land on the ground, the shock absorption, if it's not good enough in the back, it begins to transmit excess weight to the spine or to the hip and other region of the body. Now we must understand that the lumbar spine also carry out what you call segmental motion. Well, these are relative motion because many times we've asked ourselves, can I move only L1 on L2 and the others will not move, well, that's what they call segmental movement. To be able to take one segment, if I move the lumbar, I should not be able to, the thoracic should be fixed. So this is segmental motion. But moving L1 and L2 should be fixed is most difficult. But the segmental motion we're talking about here is you can be able to move the whole of the lumbar spine without moving the thoracic spine or cervical region, which we do. Now, we also know that the biomechanics of our body involve muscular support, the muscles that contract for movement to take place and the muscles that contract for stability to take place. All these are very, very important. And of course, we talk about the ligamentous support. We mentioned that the ligaments are there to support the spine on its own. You know, it connects a bone, one bone to the other. There's a very long ligament that gives external support to the body. Now, the concept of neutral spine. Do we really have a neutral spine where the forces acting on all the body become zero? Usually, this neutral spine, it shifts depending on the type of movement you're doing. The neutral spine is that point in which the load bearing on the spine is at its minimum. It's at the minimum, where each of the forces can counter the effect of the other. So we're able to get that, but it is not the same for everybody, and it is not the same for each activity. So at this point, I'm talking about neutral spine. Is why you now be coming to a patient and say, no, we want you to sit upright. For some people, when you ask them to sit upright, because that is not their neutral spine, you are putting already the back into tension, and they will begin to have problems. So you need to identify at what point is the neutral spine, where they counsel the effect of each activity. So every individual should be treated as a with its own identity. Okay? So the last biomechanics we'll be looking at is the load distribution. How do the body distribute the body weight during activities? So here we're talking about if an individual, is having trying to put on more obesity or more loading, you begin to find out that you are distorting the tension of the back. The load is getting too much, where it will become a cause of your back problem. At this point, there are patients that when you come across them, you have to be sure that you discuss how to do the weight management program with them. Otherwise, the pain is not likely to go away. So please, let's not forget that these activities, they all differ based on what we are, what we see in different patients. Now, let's look at some common causes of back pain. Now, when I say causes, we're trying to see the different etiologies. Please, I need you to know that it is different from risk factors. A cause is not the same as a risk factor. That's why we have to present the background of all these, okay? So one of the commonest cause of low back pain is muscle strain. You can see we always come in class to get confused about muscle strain and you call it muscle sprain. What's the difference between a strain and a sprain? Yes, colleagues. Somebody tell me what's the difference between strain and sprain?
I think strain
has to do with the ligament.
While sprain is the ligament.
Exactly.
Okay, that's very correct. Strain is to muscles and while sprain is to ligaments. So it means when we say there's a strain, that is there's an overstretching of that muscle, and that can lead to what? Inflammation or inflammatory reaction will be causing pain. So if this strain has led to muscles overstretching, to its either young modulus or elastic limit, then it can lead to low back pain. Another cause of low back pain is when there is a herniated disc. Disc herniation means there is either an extrusion of the disc material or protrusion of the disc material. What's the difference between extrusion and protrusion? Yes, any person? Extrusion and
Protrusion, sir, is still within the annular fibrosis. Extrusion is part of it completely, pressing on the maybe the tissues around the spine.
Can we get that again? Can we get that again?
Sir, I said I think that
explanation.
protrusion, the substance is still within the annular fibrosis. While extrusion, it has left that vicinity and is pressing on this the spine.
The first thing is what is protruding or what is extruding? Is it the annular fibrosis or the nucleus pulposus?
The nucleus pulposus.
Exactly. Is that Emezike?
Emeka Inoba.
Yes, sir.
Okay, Iloba. All right, thank you guys. I'm happy because I need that we need to follow up as we move so that it's not that I'm rushing and leaving people behind. So I'm happy that we're all together. Thank you. So these are some common causes, like I mentioned. There's herniated disc, and I said this disc can either be a disc protrusion, and that's where when we have the protrusion is when the annulus fibrosus is not broken out. Okay, so the nucleus pulposus is not out from the annulus fibrosus. That's a protrusion. Now, when you have extrusion, it means the nucleus pulposus has now poured out of the annulus fibrosus. That covering is not there. It's now on the either nerve root or whatever, causing some form of stenosis and disc compression around the region. We can also have what you call the degenerative disc disease. When we talk about degenerative, you know, it's all about aging. As the patient age, activity, wear and tear will begin to degenerate, and then the disc will begin to lose most of its water substances. And then before you know, it goes into dehiscence, and then desiccation will come there. Then you find out that in an MRI, the image will show that as if there's a calcification of the disc material. So this is degenerative disc disease. Of course, you could also have what you call spinal stenosis. So spinal stenosis can also be a common cause of low back pain. In spinal stenosis, what you have is narrowing of the cavity, okay, of those nerve roots. Where the nerve root is emanating out, when that region begin to get thickening and tightened, so reducing the lumen, it begins to form what you call the spinal stenosis. And that's why spinal stenosis is usually seen among elderly, okay? Unlike the disc problem that can be seen among young adults. So, but stenosis is more often in the elderly, except when there's a traumatic region, situation in adolescents or young persons. Of course, you could also have spondylolisthesis. Spondylolisthesis means there's a shift of one vertebra over the other. And this spondylolisthesis can either be retrospondylolisthesis or it's going to be what? Anterior spondylolisthesis. So all these are type of shift. So, and most times it's trauma that causes the shift. And many people that you will see during clinical practice is either due to trauma or aging, because as aging begins to set in, and of course, when there's reduction in the calcium level in individual, it can easily shift the spine, sorry, the vertebra itself. Another common cause is what you call the facet joint dysfunction. This is arthritis of the joints that connect the upper and lower vertebra for movement to take place. So when you have a connectivity between the lamina and the pedicles of one joint to the other, it begins to, the day-to-day movement can lead to arthritis of that joint. That's what we call the facet joint dysfunction. Of course, ankylosing spondylitis is also another cause. The ankylosing spondylitis is an inflammatory condition, and that's what we're even talking about when we have low back pain that is of inflammatory origin. So all these can be the cause of the low back pain. Infection or tumor, this is also well known in our practice. One of the commonest infection we see in the back is Pott's disease, okay? And of course, tumor, especially in males, the tumor you always see is the one that metastasizes to the spine, which is more of the prostate cancer, okay? So, but we could also see some other different ones. A genetic disease that can easily lead to low back pain is what you call the scoliosis. Scoliosis is one common disease for the low back. And this is usually very common among females than the males. But the research has come to see that it is due to their pelvic region. You know, the pelvic anatomy of a female differs from that of a male and gives you a larger carrying angle that can easily put the spine into some stress. Another serious common cause that we've not been paying attention is psychosocial factors. Just imagine the situation Nigerians were going through today. You buy something 300 naira, tomorrow it becomes 3,000 naira. If you continue to think about that, it can give you a traumatic back because it leads to depression, anxiety, and fear of the unknown, what will happen tomorrow, you know? So those psychosocial factors are also causes. Please, let's identify that causes are not the same as risk factors. So my question here is, if I identify that facet joint dysfunction is one of the things that is causing the back pain of my patient, can I still classify that back pain as non-specific or not? Yes, colleagues. Hope you're hearing me. Did you get the question?
No, sir.
Can I answer? It is specific.
Sir. Because
Did
there's
you
a
get my
structural.
question?
Yeah, it is
Yes.
specific. Let me answer.
No, sir.
Okay.
I didn't get the question.
The question is this: we have discussed common causes of low back pain, like I have highlighted in my slide. I believe you have seen it. So I now said, just imagine I evaluated my patient, and after assessment, I realized that this back pain is from facet joint dysfunction. Will that back pain still be classified as specific or non-specific low back pain?
It is specific, sir.
Now, this is where we're getting very, very
non-specific.
reasoning has to play a role. Yes, somebody said it's specific. Esther, did you say it's specific or it's Francisca?
No, I said non-specific.
Non-specific, sir.
Oh, Francisca, did you change? You change your time?
No, I've not even, I didn't even say specific. It's not me, sir.
Okay, whatever. But I thought because we have a cause now, if there is no cause that is a facet joint dysfunction, why are we still saying it's specific? Yes, why are we still saying it's specific? You are saying it is a specific low back pain. It means, are you going to put that back pain under the 5% low back pain we're talking about? Alima Ibrahim, can you mute your phone or your device? Thank you. All right. Yes, please. somebody should tell us, why do we still maintain that it is a specific low back pain? Don't forget, in the classification, we have mentioned what
It's not attached to any pathology, sir. Any red flag, no red flags.
Are you saying it is specific or non-specific? Because if it's not having any red flag, it means it's not going to be specific.
It is specific because it has a cause. You can trace the cause.
Exactly. This is where I want us to use our clinical decision reasoning. Yeah.
It has a cause. It has a cause.
I said we have been able to identify that the cause of this back pain is from facet joint dysfunction. And then we know that if a back pain is not attributable to a specific cause, we'll say it is a non-specific low back pain. Okay? Now, we have attributed it to this cause. Is it still going to be non-specific or is part of the specific?
Specific.
Specific.
We have known the cause.
It is specific, yes, because
now the truth is that for you to have a facet joint dysfunction, it means all the structures of the body is already affected. You agree with me that if you are having arthritis, it shows that it is not just one part of your body is affected. The affectation will have gone through the synovial membrane. It will have affected the muscle strength. It will have affected all. So you believe with that, right? The cartilage and all that are all going to be affected. So it is not one specific thing. That is why it's still classified as non-specific low back pain. So I want us to understand it that it is only when there is one specific cause, just like saying it's infection, it is a tumor, okay, or it's a fracture. So that is what we call specific low back pain. Any question here, please? I hope I'm not confusing us, and that's why I don't want to move out of this side.
So I think you confused me a bit.
So please let's clear this side. What's the confusion coming from?
All right. So you spoke about that specific is when you know the cause, when you know the exact cause.
Yes.
And then non-specific is when there are several causes. It could be neurological. It could be muscular. It could be muscular.
When we cannot attribute it. When we cannot attribute it to a specific cause.
Exactly.
Yes.
So just now you kind of like.
And I gave you a scenario that one of the causes of back pain is a facet joint dysfunction.
Yeah.
Right? So I'm now asking you if facet joint dysfunction is what you have identified as the cause of this back pain. Will you still classify this back pain as specific or non-specific?
It will be specific because I have attributed the cause. I have evaluated and confirmed that it is.
Yes, because you are attributing it to what? To the facet joint dysfunction, right?
Yes, sir.
Now the problem here is because you have not read deeply about the facet joint dysfunction, you will know that the facet joint dysfunction is also a conglomerate of different affectations that led to it. Okay. Do you understand? I said facet joint is just like dysfunction is just arthritis of the joint. And arthritis means a lot of wear and tear and degeneration is taking place in all the structures in that joint. Is that not true? Gabriel?
Yes, it's true. Thank you, sir.
So you see that I cannot say it is just the muscle that is affected. I cannot say it's just the cartilage. I cannot say, so it means it's also still what? Non-specific.
Yes, sir. Thank you.
All right. So are we all happy with that? Can we move forward?
Yes, sir.
Right. Thank you. So let's see some risk factors for low back pain. I said among the risk factors, we have age, right? We have occupational factors, the type of job you do. We have lifestyle choices, talking about physical activity level, or talking about, sedentarism, or talking about your choice in trying to become obese or not obese, or somebody who is indulged in alcoholism and all that. So those are lifestyle choices. Of course, your physical fitness level is what you talk about being physically active and not active in sedentarism and all that. Of course, your previous low back pain episode, people with previous low back pain are at high chances of recurrence than someone who has never had it before. So if you have low back pain before, then know that you are at a risk of another low back pain. Among the risk factors we're talking about is ankylosing spondylitis, because it's genetic. So if you're do we know about ankylosing spondylitis? It's a genetic affectation that leads to people or the individual having an added genetic composition of HLA. Is it HLA-S4? There's this G that is in these people. So you can say you did not create it yourself. It's just genetic, okay? And we say psychosocial factors. Now, how do we differentiate the psychosocial factors as the risk factors and then as causes? How do we differentiate?
Hello, sir. Okay. I think I can say that when you have discovered that the psychological factor or social factor is the cause of the back pain, then you can move it to cause as a cause factor. But
I'm trying to ask that here between how do we differentiate between a psychosocial factor as a risk factor and as a cause?
Yes, that's what I'm trying to say. That
okay,
when somebody is exposed into, when you discovered that your patient is vulnerable to such psychosocial factor, then it's a risk factor. But when after you have done all your checks and discovered that that person is having a psychological effect that caused that back pain, then you move it to a cause, as you explained earlier.
Yeah. Do we agree with that, or somebody wants to add into his discussion? Can we have somebody give us expatiate on that?
It can be psychosocial because the person's state of mind and well-being affects his or her feeling of low back pain. If the person has a low self-esteem or is financially incapacitated to one means or the other, and that leads to depression, eventually it leads to turn on that structure because he will not be able to have the courage and the confidence to use his or her body the way he or she ought to use his body. So eventually it begins to turn on the spine, eventually, and begin to lead to hanging on the lower back, and which eventually can lead to low back.
Dr. Udi, it seems you're far away, but I could barely hear you very well. I'm hearing your voice, but I'm not catching your words properly. I don't know if you can come closer, or you're using Bluetooth device.
I'm using a Bluetooth device for amplification.
That's giving us some reverberation.
Yes, sir.
All right.
I said the individual's state of mind affects his or her own body because when the individual is depressed due to emotional or financial constraint, the constraint financially can affect the individual's outlook in life. That can lead to depression, which eventually shows on the musculoskeletal system of the individual, which can eventually lead to back pain. Because the individual has lost
my question is this, Mr. Udi. At what point do you know that this psychosocial factor is a risk factor or is a cause of the low back pain? How do you differentiate that? At what point?
When you allow the patient to perform certain activity and he or she is unable to do it. For example, the patient comes into your office, clinic, and you ask the patient to sit down. When the patient sits down or she sits down, you can watch from the appearance the patient is presenting. By just sitting down, you can observe from just looking at the patient, the outlook of the patient. You will be able to tell if the patient is excited or if the patient is depressed. You can see from just looking at the patient, by just looking at him while he or she is sitting down opposite you in the clinic. You can see from there.
Great, great. Those are good. Yes, those are great information. And those are the things I'm wanting to pick from what you're saying. Okay, so we want you guys to know that these things are interconnected and interrelated. And you need a very sound clinical reasoning for you to be able to capture this. I don't know if somebody can make it much more clearer to identify a psychosocial factor as a risk factor for low back pain and a psychosocial factor as a cause of the low back pain. Can someone else also give us another scenario or explanation?
From history taking too.
Beautiful, beautiful. This is just what I'm expecting from your evaluation. During history taking, what would you want to know? What would you ask? Francisca, please go ahead. During history taking.
Yeah, the way the patient is viewing his condition, the way he's talking, so you can know that, okay.
Yes, during evaluation, this history is the simple thing. A patient is talking to you, and she mentioned that her back pain started, 2 months after her husband divorced her. Just take that, for instance. Is that not giving you there is already a risk factor?
Yeah.
Do you get my point? Now, when you are now evaluating the patient and you ask the patient, I want you to move from this point to that. So okay, I cannot move. You see, there is fear avoidance belief. You get my point now? So there is either fear of catastrophizing of the pain or fear of avoidance. All this will tell you if this is what is causing the problem or this is what led to the problem. So this is just where I'm trying to point out so that you don't see psychosocial factor here as a risk factor and psychosocial factor over there as a cause. So there are points where you'll be able to differentiate. Is it coming as a risk factor or is coming as the cause? Are we happy? Can we move forward from there?
Yes, sir.
Thank you. Now, we also mentioned that during our epidemiological studies that gender has little or nothing about the prevalence. But what about having females to present more with back pain than males in our clinic as risk factors?
Females present more in the clinic as risk factor because of the way their pelvis, their anatomical structure is designed. They have wider pelvis, and at certain stage in their life cycle, they normally go through the certain gestation period when they involve when the woman becomes pregnant, for example, and during the later stage of pregnancy, there's a lot of hormonal release, and because of the secretion of excessive hormones to prepare the patient for eventual labor and delivery, the areas around the pelvis becomes very slack and very lax. Because of the laxity in these areas, if the patient is not aware and is not taught how to position herself while sitting or while doing domestic chores, eventually after delivery, the patient can come back to the clinic and present with low back pain because the anatomical structures around the pelvis have been overstretched during child labor. That can also cause low back pain.
That's true. Well, basically what I'm trying to point out here is we should know that females are likely to cry about their problems easily and faster than males. most male will feel keeping to their problem is a type of manhood thing. It gives them that complaining of back pain is like you are being lazy. So they keep it to themselves until when it becomes unbearable. So, but females are likely to come out as soon as they have a complaint. And of course, the issue you mentioned, talking about pregnancy, child delivery, and all that are all vulnerabilities that can make more women present to the clinic than males. So these are the issues. It doesn't mean if you go out in the community to do a gender study, you are going to see any more significant difference between males and females. It's just presentation to the clinic that you see more females than males, not because the males don't have the problem. So that's why when you go and read epidemiological studies and they are telling you there is no any gender difference between male and female, it's understandable. Okay, so I said another risk factor we should know is issue related to posture. When people have poor posture, you know, they're likely going to traumatize most of the back structures and they're likely to present more into the clinic. Lastly is traumas. I said when people have trauma or injury due to road traffic accident, all this may increase the likelihood of secondary arthritis and of course low back pain. In traumatic situation, more males are expected to present because it's trauma related. More males are involved in high risk behaviors. You know, they're likely going to show up than females. So these are some common situations we must present to ourselves and know that this is how the situation works. Now, I haven't mentioned this. Let's see how we should understand this low back pain. I said the non-specific low back pain is defined as a low back pain not attributable to a recognizable non-specific pathology. This is where I've become this is where I'm trying to harness that it doesn't have one recognizable specific pathology. Okay, so I said non-specific does not mean that there is no tissue causing the problem. It's just that it is not clear and not as concerning like what we say it's infection or a tumor. I hope, Gabriel, this will help you make clarification from the earlier post discussion we had. This will put us in the right perspective on how to understand non-specific low back pain. I said one serious spinal pathology and specific causes of back pain have been ruled out. An individual is classified as having the non-specific low back pain. But as long as no serious pathology is suspected, we should know that imaging is not indicated unless if the imaging may change our decision in the management of that patient. This is where most patients spend their money so much in trying to do x-rays, MRIs, and all the bone scans, okay? So we will rule, as long as you're able to rule out any specific pathology, you will not be able, you should not bother going to do an x-ray. In most of your patients, when you send x-ray, what would you see? The highest they will write back to you is to say that the patient is having either mild spondylosis, or they tell you moderate spondylosis or severe spondylosis. Whatever it is a spondylosis. Does spondylosis tell you anything you're going to do in the management of that patient? Do you use spondylosis to make decision on your treatment pattern? No, colleagues? Are we there?
The diagnosis, it only acts as a guide.
You said?
Don't. So spondylosis, that's a medical diagnosis now.
It's a medical diagnosis. It's not a physiotherapy diagnosis at all.
We are going to
where the
manage
problem
what
is
we
the radiologist does not know what physiotherapists need. So he's not going to write you the way he writes to the medical doctor. And the medical doctor, of course, does not have anything to do with the spondylosis. It's not going to change your treatment. So please avoid as much as possible writing for imaging when it's not really indicated. It's as long as it's not going to change your line of management. So this is what I'm trying to come up with. I said non-specific low back pain is usually categorized into acute, subacute, or chronic. This subdivision is based on how long the individual has had the back pain. Acute low back pain is an episode of back pain that is present for less than 6 weeks. We usually say between first 2 weeks, okay? So, but the subacute one is between 6 to 12 weeks, which usually starts in the 3rd week. The chronic one is after 3 months, which is 12 weeks and above. So if you look at this classification, this according to the American Orthopedic Society. Now, they are still classifying that if the back pain continues to be there for the first 6 weeks, it's still acute. But what should be known is if a patient presents with low back pain for the first time, and then this back pain, you're able to take care of it in the first 2 weeks, and the patient has no longer symptom. Okay? Now the patient is discharged, or you allow the patient go. Within that 6 weeks, after the first episode, the patient now return back to clinic that is having some little pain. Do you still go ahead that back pain is still acute or is in the subacute stage? What do you say?
It's in the subacute stage because it has elapsed the initial 2 weeks of the acuteness of the pain. So it's less as subacute. Because the severity of the pain is not as much as it were when the patient first presented.
Exactly. Because the reason why we must get it clear here is if you move your patient out of the acute stage, it means the treatment you're going to be designing it will differ from when it's now in the subacute phase. And that's why we have to be very sure which level the patient is based on this classification. And that will inform your decision on what are the treatment models you should use. So please, let's get that very clear. Sometimes it requires a lot of iteration. That is, every now and then repeating those things to give you a specific sign. What I normally use here is what is the duration of pathology of inflammatory or acute inflammatory reaction in an individual. You'll find out that the first acute reaction starts between the initiation of the problem to the first 72 hours. Is that correct? Now, within the first 72 hours to 2 weeks is where you expect that there's going to be resolution, a complete resolution of that acute phase. So that when the patient is coming back between after the first 2 weeks to another maybe 1 month, is still not out of the 6 weeks, and then he presents with some complaint again, you should not go back to managing with the acute phase issue. You should start thinking now we're going into a sub-acute phase so that some other treatment modalities, some other treatment patterns will begin to go into it. Are we together?
Yes, sir.
Good.
Yes, sir.
So, we've mentioned that these non-specific pain are not attributed to any specific pathology, and usually they are typically mechanical and they are not radiating. So, our major concern is how do we exclude other diagnoses to remain at what? Non-specific low back pain. And that's where we should be paying attention during our assessment and management. We should know that non-specific covers about 80% of all adults experiencing pain. And we have agreed that the non-specific back pain is the leading cause of disability in the whole world. And a lot of money, as I've mentioned earlier, is being sunk into this. Now, our major concern is that when we have this non-specific low back pain, what we normally know is the biomedical model. And this biomedical model, it focuses on tissue and pathology. That is, we look at, okay, it's a disc problem, let's begin to work on the disc, okay? But we should know that things have changed now. We should not stop on this tissue level, because most often you will find that non-specific low back pain is not related to any pathoanatomical problem. So how can we now treat this problem? They say we should begin to think about the biopsychosocial model. And this integrates both the biological, psychological, and social factors. Usually, the biomedical model will always tell us that pain is attributed to a structure or anatomical causes. Okay? Assume now there's a linear relationship between tissue damage and treatment. All what we do is go and do X-ray, go and do MRI and all that. We do medication, then rest. At the end of the day, they do a surgery. Now, there's a limitation here. I said 90 to 90% or 95% of people with non-specific back pain, they lack specific pathological source. This is the reason why even after surgery, most of the patients will come back to you with a problem, because what they are going to do the surgery might not even be the reason of the pain. We have seen this several times. Even evidence in MRI studies have shown that over 90% of people that will have disc problem or pathology in their MRI of the back may be asymptomatic, will not even have any concern of pain. It means most of those, again, that are having the symptom and then having the pathology, you will see that when you go and treat that pathology, the symptom will still remain, because it is not that pathology that necessarily leads to that. So these are all limitations. And therefore, we begin to think of where to go from here. And this is when we start thinking about the biopsychosocial model. In the biopsychosocial model, we talk about the biological problems, which is about tissue strain, joint dysfunction, and others. Okay? Now we know the patient has a tissue problem or strain, he has a joint dysfunction, we have recognized that. Then, but we have to assess the patient for issue concerning his psychological well-being. What is the present status about fear, anxiety, and depression? You know, what is the social interaction with this pain? Is this pain leading to loss of his job? Or is that the family are abandoning him? Or the office is not even giving him support on what to do? So this is where we begin to move into the psychosocial, biopsychosocial model. Our colleagues, can I just take a break for like 5-10 minutes? I need to get some water. Okay, please just give me 5 minutes to have a break. Okay, thank you, colleagues. I'm back. Can we continue?
Yeah, welcome, sir.
Thank you.
Yeah, welcome. You can continue.
So,
Continue.
the biopsychosocial model was developed by George Angel in 1977, so not very long ago. It's less than 50 years that the psychosocial model came about. The man is a sociologist who identified that pain is not only influenced by pathology or the tissue damage. They said pain is influenced by both biological, psychological, and social factors. And he said, for you to be able to treat, especially non-specific low back pain, then you must be able to promote an active, holistic, and individualized care. So therefore, the mention that is the new pattern and way to go by. Now, let's look at just a fictitious case. I present a case of a young woman. I call her Aisha AQ. You know, she's a 35-year-old teacher who says she has non-specific low back pain for 6 months. Now, if we look at the biomedical approach, what they will do is at the first, they will give her medications, injections, and all that. By the time it's not going up, they will come back, okay, go and do MRI. In fact, they can do multiple MRIs because the first MRI may not show anything due to inflammation. Second MRI may not show. They might ask us several MRI and X-rays, which we normally know about this. So all these may not show anything serious until they will now make a diagnosis of maybe disc bulging. Then the treatment will still continue to be analgesic and eventually maybe surgery. Now, nobody will care to assess activity level. Nobody will try to assess her fear. Maybe she's got fear of paralysis or fear of so many things. So, but nobody will do that because this is a biomedical problem. In biomedical approach, all they keep seeing is that they will be treating the X-ray or treating your MRI or treating your lab result without treating you as an individual. It's not the person that matters. It is what pathology is showing that matters. You know, even when the patient is telling the doctor, doctor, I know myself, he will tell you it's not about yourself. This is what your result shows. So that's what is called the biomedical model. Okay, it's not about you as a person. It's about the MRI or the X-ray or your laboratory workout. So whatever you are telling the patient, the doctor, they will not consider you. They will rather consider what they see, and they believe that pathology is what must be treated. So we realize that this is what is not making most patients with non-specific low back pain get better. And therefore begin to use the biopsychosocial approach. Now, in the biopsychosocial approach, often after we have understood that there is a pathology, especially in the X-ray or MRI, whatever, you have been able to evaluate that there's a disc bulge and all that. The first thing we should do is to educate the patient on pain science. You know, pain is not all about the pathology. Pain can be influenced about how you think of that problem. I'm sure most of us here must have had one or the other type of pain. As medical personnel, anytime you have any serious pain, what do? We begin to think of the most disastrous type of things we have read before. I remember during my undergraduate days, if you go and read any pathology, you come back and you feel your hand is having that thing, you will tell yourself that it is that disease you have. You will never think of anything simple. You will be that corneal disease. They talk about myasthenia gravis. You think, I think I have this myasthenia. The day they go and teach you something else, you think, I think I have this based on this symptom. So we will always think of the most difficult thing, and that scares us most. When a doctor or a medical personnel is sick, his own sickness becomes worse because he begins to interpret those things with what? The highest level of knowledge and disease that he knows. I don't know if I'm connecting with you guys.
So I am very 100% correct. I'm a witness.
No, thank you very much. So this situation means we would need to educate the patient on pain signs, letting them know that this pain is not necessarily about the pathology. For instance, you tell a patient that today you didn't go to work, and what happened is that for not going to work, maybe the governor was in our office and he shared 10 million. So you have lost 10 million naira today. Do you think he will be thinking about the pain of his back or the pain that he has lost 10 million naira? You don't understand that?
Yes.
So when you educate the patient, this thing it doesn't mean because you have pain, your MRI shows this. No, many people can have that and know any pain that they are going through. So the pain science will help reorient the patient's understanding of pain. I'll give you another scenario. If you take our cultural perspective about pain, let me give you this. You take a Fulani man, you take an Igbo man, and a Yoruba man, and how they perceive pain. If you take a Fulani person, and you tell the person that we're going to hit you with this stick, and until you show your heroic stance, before we give you a woman to marry, that you have to paralyze. Let me hit you with that stick 10 times, before they will give you a wife in the front of everybody, in the presence of everybody. That Fulani man will go out there to show that he's a hero. He will stand until you knock him all those 10 things, and then he will stand up and go without any shaking. Does it mean his body is not feeling pain? No. For him to show a hero aspect in the front of every person is what gives him the kind of personality he's looking for. If you take a Yoruba man to go and say they will hit him 10 sticks before they give him wife, will the Yoruba man agree? He will never accept that. Same will likewise the Igbo man. But for the Igbo man, if you tell him, look, if we give you these 10 sticks, you are going to get 10 million naira, will he stay or he will not stay? Because he has his type of culture is oriented in what? Success. His success is about how much is coming out into his account and how much is going out. If you want to give it, he will tell you instead of 10, give me 100, so that you add another 10 million. Because that is what he sees as his own something. No, you see that all these people are not feeling the pain. They feel the pain. It's the interpretation. The Yoruba man has interpreted that if you flog me, I will die. So no matter what he will give you, he will not do. The Fulani man feels that is the only way to show you are a hero. And that it is better to die a hero 1 million times than to die 10,000 times or something like that they used to say. That it's better to die a hero once than to die of a coward 1 million times. And you understand that? So all these are perspective. So if you don't reshaping the understanding of the patient, it's what normally leads to catastrophizing of the pain. Because you begin to interpret it, most times the patient will come to you, doctor, I think it's my kidney now. This pain is here. He will be thinking that it's his kidney. Maybe somebody has told him that a kidney patient has pain like this. He will say it's his kidney. He will tell you, no, I think, doctor, my liver. I think it's in my heart. So they will interpret it in a very wrong way, and then that will lead to fear and so many problems. So this is why the biopsychosocial approach is very important. And of course, the biopsychosocial approach knows you have pain due to a pathology, but it tells you need to learn how to move around. That the more you sit down, the more the problem will bring you down because of disuse atrophy. So it encourages you to walk and exercise. That gives you that the patient has ability to move. And of course, it addresses the fear avoidance beliefs. The biopsychosocial will not let you entertain fear of this movement. And eventually, it helps you to return back to your work. And it supports you. So these are the major reasons why we need to go back to biopsychosocial approach. And now for us to do this approach, We will need to evaluate and assess our patient in all these domains that I've mentioned. Several studies have shown us that the biopsychosocial approach has given a very good outcome in terms of pain reduction and disability and activity resumption. So this makes it one of the best way to do that. Let's see, how do we now assess our patient? Because we're now going into now the practicality of today. I say assessment tools, usually we start with our subjective history, just like when we are clocking our patient. We clock the patient to identify the pain history. When did the pain start? What is the nature of the pain? What is the pattern? So all these are things we will do that helps us to understand how we move. Of course, we will assess the patient and how their function have been impacted. It is how do you move from where to where, movement ability, your impact on your activity at work, your activity in at home, leisure time activity. All these we'll try to assess them. And we say we'll use different tools. So we're going to see that as we move. Our assessment also involves physical examination, trying to observe the patient in terms of distress in pain. Like somebody mentioned that when a patient presents, we can see from how the patient is composing himself, if they are in fear, if they are in serious distress of pain or respiration. All these are observable. Of course, we'll assess for active range of motion, we'll do palpation, some neurological screening, and then functional movement testing. I talked about we need to screen this patient for red flags. Because we need to know when is it that this patient, is he either a non-specific back pain, is it a serious spinal pathology, or it's a specific neurological factor with neurological condition. Now let's look at red flags. I said a red flag is a warning sign or symptom that may indicate a serious or potentially life-threatening condition. Just like what we say, this is a red flag. It means don't go there. Even in a relationship, we say when you see somebody exhibit ABCD, it's a red flag. So when you see your patient exhibiting red flag, it's a warning sign or symptom which will show or indicate a serious or potentially life-threatening condition. Red flags are clinical indicators that prompt Oh, sorry, I did not know we lost connectivity. Are we all together now?
Yes, we can hear you now, sir.
We're
You can
together,
hear me
sir.
now? Okay.
Yes, sir.
Were you with me when I started the red flag?
Yes, sir.
Okay, good.
Yes.
So you can still see my slide now.
No, sir.
Oh,
Okay, I
sir.
need to share. Okay,
We can't see the slide.
Okay, let me share it again. Okay.
We can see your slide now, sir.
Okay.
We
So
see
let me
it,
just
sir.
go back. Yes, let me just go back and mention that the red flags are warning signs or symptoms that may indicate a serious or potentially life-threatening condition. Red flags are clinical indicators that prompt a healthcare provider to investigate further and consider the possibility of underlying pathology or a medical emergency. I said red flags are used to identify conditions that require immediate attention or further diagnostic evaluation. I said these red flags can vary, but they are commonly associated with signs and symptoms or some patient characteristics that suggest the need for an urgent medical intervention or further investigation, like we have mentioned. Healthcare providers identify red flag. Identify red flag is essential for healthcare providers to ensure a timely diagnosis and appropriate management of serious medical intervention. Okay, so what are these red flags we should see? No, one of the red flags is a severe or progressive neurological symptom. When you are looking at a patient and you see a patient who presented with you with muscle power 3 a day before and the patient returned, the power is now 0. That is a serious medical problem. So we need to see why is it that the patient is having a progressive weakness or numbness or tingling sensation? Because all this suggests that there is a compression or a spinal cord involvement. So you must try to call attention of a medical emergency. Another red flag is when you have a bowel or bladder dysfunction. A patient whom you see and is incontinent in both urine or fecal incontinence is a serious red flag that demonstrates there is a cauda equina compression or a spinal cord compression. Also, when patient presents with recent trauma or injury on the cord, maybe following a road vehicle accident or fall from a height. So if you see a patient with fracture in the spine, it shows that this is a red flag. I'm sure as a physiotherapist, you don't want to start treating a patient with fracture in their spine. You know, the doctor will be happy to see that it is the physiotherapist that lodge a compression on the cord so that they will be able to say, we've told you they don't know anything. Okay, so one has to be very careful, especially for all of us that are trying to move outside the shores of Nigeria, you know, especially going to practice in the UK or US, where litigation is always high. You want to be very, very careful, otherwise you lose your license and practice from there. In fact, you can lose your certificate. You know, so people can be pulled in jail for life. So please, you have to be very careful to evaluate and assess your patient carefully for red flags. Imagine an Oyibo man now, you just go, you are the one that, you know, try to manipulate the spine, and when there's a fracture already, the patient is now coming with incontinence. They will never forgive you. You know how they are there. So please, let's be very careful with that. Of course, patient that comes with fever or high, you know, the fever is high or signs of infection. So most of these type of patients, they bring you a patient to treat, and the patient is having a temperature of over 38 degrees centigrade in the body or 40, and then the patient is feverish, chills, and unexplained weight loss. So these all can be red flag for either osteomyelitis or epidural abscess. So you be very, very careful to learn how to eliminate such that. Of course, a patient with recent history of cancer, you know, so if the patient has never come up with history of cancer, but the patient tells you begin to evaluate, you see like a gibbous and all that, you have to dig further to be able to know if that thing is as a result of a cancer or metastasis from somewhere else, like from the prostate gland. So you should be able to capture all this. These are all red flags. Of course, it is also a red flag when you see a patient who is an elderly patient, especially after age of 50, and then is presenting with a very high intensity low back pain, or a young patient less than 20, 15, presenting with high serious back pain. All these are red flags for you to know. Patient that presents with pain that usually occurs at night is a nocturnal pain. That pain is only at rest. You know, that is supposed to call your attention that is what? A red flag, because your pain is supposed to be related to activity, not only that when you want to be at rest. This nocturnal pain, especially if it disturbs the sleep, can be an indication of a kind of malignancy. So one is supposed to understand and know when to go and begin to probe into such pain. If your patient gives you an history of prolonged use of steroids, this is also causing, we call for what we call a red flag, because long use of steroid can weaken the body immunity as well, weaken all the spines. Okay, so it means the patient can lose most of the calcium of the body, and anything can lead to pathological fracture or osteoporosis. Of course, when patient also present with use of intravenous drug, that is a patient who is a drug addict due to any kind of source of, smoking or use of hard drugs, can also present with such situation. So one has to be very careful with what you do at all times. All right. The moment we've been able to do our screening of red flags, we'll know where we're going to put this patient. Please, if your patient is not a non-specific low back pain, or at most a patient with low back pain with radiculopathy or with nerve, what you call neurological involvement, don't treat the patient, refer the patient. The patient comes to you with any serious spinal pathology. This red flag is what cancels the patient from your physio clinic. Send the patient to the GOPD, or send the patient to emergency, or you send your patient to the orthopedic group. Let them go see what they will do. After the patient is stabilized, the patient can come back to you. This is not showing that you don't know what to do, but it is showing that you want to stay at the within the scope of your practice, and it has demonstrated that you are not going to involve yourself in any litigation problem. Okay, serving yourself is serving your profession as well. So please, let's be mindful with all that. In this case, okay, we're supposed to now see our outcome measure, which are the major things we want to do today. I said in assessment, we need to use outcome measures. And these outcome measures must be standardized patient assessments. At least it should not be that what you are using, people don't know it. You can't say, no, this is something I developed myself. It has to be something that is well known and standardized. It must be valid, reliable, and it must be what? It must have good psychometric properties. Now, I was asking, why do we use outcome measures? I said, number one is that we use to standardize our patient assessment. If we are using outcome measure, it means what I will be talking to you is the same thing you'll be talking to me. It allows good communication between the specialists that are managing the patient. It allows communication between the patient and the specialist, you as the physiotherapist treating the patient. Outcome measure helps us to guide our clinical decision making. If we don't have a good outcome measure, then we will not be able to say this is the best thing that will fit this patient most. We also know that outcome measure help to monitor if the treatment we are giving is effective or not. So the treatment effectiveness will be monitored using good outcome measures. First, I've mentioned that it helps us improve our communication between patients and colleagues. And then we know that outcome measures, they support evidence-based practice. So if you cannot just come and ask the patient, Mama, how are you feeling today? How is your pain? The patient said the pain has reduced. So you just write, patient mentioned pain has reduced. From what to what? Nobody will accept that if you have not measured and quantified it. And most patients will even tell you it has reduced because they want to appreciate your effort. So it's just subjective. It's just telling you to make sure that you are happy with what is going on. So let's look at the different categories of outcome measures. And these are the essential outcome measures we must know about and use in non-specific low back pain. So for these outcome measures, one of the basic things is about the pain. We say we are looking at low back pain. Low back pain is not a disease, it's a disorder. Okay? So it is the pain that is the concern the patient is coming to you. So it means what I need to do first is to do what? Assess the pain intensity. So that's one of the first category of the outcome I should do. Pain intensity. The second one is functional disability. Because I know when people have low back pain, they begin to lose some of their function. So I needed to know how much function does the patient lost. Of course, apart from functional disability, you also have the psychosocial factors. So this is where we talked about all those issues relating to fear and depression and so on and so forth. How is this patient understanding the problem that he has? Of course, we look at quality of life, how much has been affected in the quality of life of that patient. So if the patient telling me that the pain is 8/10, but she's happy with how she can, she understand her pain and all that, it means we have been able to enhance our quality of life even though when there is pain. And of course, we should learn how to do what they call the patient-specific goal. A patient, you will assess the patient and come to the conclusion, okay, you have this problem. The patient-specific goal is that you ask the patient, among all these things you have identified as your concern, what will you be happy to see that is the first thing we have taken away for you? So patient might tell you it's not the pain. The patient might say, I want to be able to go to my office, and make money. If that is the concern, then you know that this is the patient's specific goal, and you must work towards that goal. So please, these are different categories I want us to put at the back of our mind. See pain intensity measures. If we want to measure pain, there are different outcome measures. And we must understand which one will give the best outcome measure. Yes. So who can tell us what is pain intensity? How do you describe pain intensity? Or what is pain? Tell me, what is pain? Yes, any person who's still connected, because I've not heard any person's voice.
Yes, sir. We're here.
Sir,
Yes.
sir,
Go ahead if you can hear me.
Can you hear me?
sir, can you hear me?
Yes, I can hear you. Go ahead.
Okay, sir. Pain is a sensory or emotional sensory or emotional experience, which is a. Sir, can you hear me?
Yes, I can hear you. Go ahead. I can hear you. Nur Abdullah, go ahead.
So pain is essentially or emotional experience, which is pain is essentially or emotional experience, which is associated with actual or potential tissue damage or expressed in form of such damage. Am I communicating?
Yes, you are communicating. Nura, go ahead.
I said pain is essentially or emotional experience, which is expressed in form as a result of tissue damage, or it is associated with actual or potential tissue damage.
Okay, perfect. That's pain. But you know, this is more of a technological or technical definition. What is pain as an just generally you want to tell somebody, because pain is a universal language. Everybody understands what is pain. A baby, after the first time she touches a hot something, the next one she tell you, no, it's painful. So how does she recognize pain? What is pain? Please,
let me try that. Pain.
Yes, yes.
Can you hear me, sir?
I can hear you. Is that Dayo? Go ahead.
Pain is a feeling or discomfort that someone may have, and it can be emotional or based on potential injury to the body.
Yeah. You see, that definition, there's a specific word that I need you guys to bring out. Nobody has mentioned it. He said it's a discomfort. Somebody does not necessarily have to have a discomfort to have pain. But there's something that is a commonality among every person that has pain.
Hello, sir. Can I say something?
Yes, please go ahead.
A pain is an unpleasant sensory or emotional experience as a result of tissue damage.
Yes, this is just the point here I want us to make. It's an unpleasant. Does anybody like pain? No, nobody likes pain. So it's an unpleasant experience. And that's why I mentioned to you that a baby who doesn't have never had pain just went to touch something hot. That is the first time she's experiencing the pain. So the next time she will not touch that hot thing again because she has gotten the experience. Okay, so and that experience she got was unpleasant. It's not likable. Okay, so this pain is unpleasant. Now, in this context, we're saying it's either indicating a real tissue damage or a potential tissue damage. Yeah, somebody has dropped something on the audio. He said they cannot hear me. You hear me now? Am I audible now?
Yes, you are audible, sir.
Yes. Okay, good. Now, what we're trying to say is this sensation that we say pain is an unpleasant sensation or an unpleasant experience. It is this experience we're talking about is related to either an actual tissue damage or a potential tissue damage. That is, it has the ability to damage something, or it's not having the it's actually damaging something in you. And this is where the issue of fear comes around. Now, if I don't know what is damaging, I'm going to get scared of this pain again. And this is the reason why many people come to hospital. It's because of the pain. Okay? So, now that you have come to me with this pain, I needed to assess what is the severity or intensity of the pain. And if I have to do that, I need to use an outcome measure. What is this outcome measure I'm supposed to use? It's what we are looking for. And that's why I said these are the various pain intensity measures. The first one is the visual analog scale. Now, the truth is, no matter what type of pain intensity measure you're using, it's still going to be what? Subjective. Subjectivity in the form that you can't have an instrument or a tool that you will insert in the body of the patient and it will read that this is the pain intensity level. It's not there. All you can do is, I can ask you, you know, this pain is from this level to that level. I need you to mark it. Now it's subjective. But whatever it is, anything a patient tells you he or she has pain, you must accept that they have the pain because you don't have an objective tool. For instance, if I want to measure your blood pressure, I don't need you to tell me if my blood pressure is normal, my blood pressure is not normal. That is not my business because I'm going to use a tool to measure it. If my sphygmomanometer shows that your blood pressure is normal, I record that it is normal. But do you have the same type of tool to measure for pain? No, we don't have, because we do not have an objective tool. It means it is same the patient that will have to contribute and speak to us how about that pain. Now, if we agree that pain is subjective, but we try as much as possible to make it as objective as possible, you know? No. Now, the major issue here is you must use objectivity in the subjective nature of that pain. And this is the reason why we are creating all these tools that we're mentioning. So in visual analog scale, we create a visual parameter. You know, a ruler is used to draw a 0 to 10 centimeter mark. And you are asked to look at this mark, that this point means 0, there's no pain. And from here to the end means this is the highest pain. So between the 0 and 10 centimeter, you are asked to mark on that scale where you think your pain level is. So when the patient marks on that spot, you will use the 10 centimeter ruler to assess. And that's where we bring about the objectivity. And now maybe between 0 and 10, you got that the patient has marked 7 point something. So you now know that this pain is at 7 or 7 point something mark. We would ask to now be interpreted. If the pain she has marked is 7, what is the interpretation of pain 7 cm on the Do we understand this? Because most of us have always misused VAS and the numeric rating scale, or the numeric pain rating scale. For the numeric pain rating scale, you tell your patient that if your pain is 0, if your pain, you don't have any pain, it means it is 0. And 10 is the highest pain you have ever had. Between 0 and 10, where can you tell me your pain is? That is the NPRS. So that is not the VAS. And most of the time, people will use this and be recording it as VAS. For VAS, you have to measure a ruler. And the patient will have to write on that ruler, that piece of paper where you drew the line. And then you have to measure for you to assess VAS. Of course, you also have the VAPA rating scale. In the VAPA rating scale is just as good as the 0 to 10. But in this case, you just ask the patient to tell you, what can you quantify your pain? You know, from 0 to whatever. Tell me where is your rating? What will you rate the pain? You think your pain is mild, your pain is moderate, or is severe pain you're having now? That's a VAPA rating scale. I don't know if I'm communicating at this point, because the network seems, I think, is not stable for everybody.
You are communicating, sir.
Okay. So here it's what we want to say is for you need any of these measures to be able to rate the scale. Okay? If I now want to assess pain in children, which one am I supposed to use here?
For children, the visual analog scale.
Now, imagine I have a 2-year-old child, which I want to assess for the pain he's having. What will I use? The visual analog scale?
Is it not one baker?
But sir, there is pediatric pain rating scale.
That's what I'm asking you. Even if it's a pediatric rating scale, how will I use it for a child? Have you guys not been rating children's pain in your pediatric ward?
Yes, sir. You can utilize the facial expression of the patient.
Oh. You said what?
Yes, sir. You can utilize the facial expression. There is a one Baker rating scale that has a different facial expressions. So
Actually, that is where we're going
use
to
that
let you know that it is not an exhaustive list, okay? Because all what I've mentioned here cannot be used in children. For the children's case, you need to have a visual, a facial pain rating scale. It has to be pictorial because the baby cannot tell you my pain is 2, 3, or 4, or whatever. So you only look at the grimaces. When you touch the patient and you see how the face is communicating with you, then you will know what to give based on the pain rating scale. Okay.
Hello, there is one Baker's scale.
Yes.
Whereby you can
use
the
that
expressions of the patient, and it's being rated from 1 to 10. The expression of the process from the children we quantify the extent of the phase of the pain, and that is what is used to rate pain in
Yes,
pediatrics.
it is still a facial expression.
Yes,
that's what I'm saying.
That is it. That is it.
Yes, it is still a facial expression. So my point here is we should know that most of these lists are not exhaustive. Sometimes we pick it only on adults. We don't go back to the children aspect and other types. But we must understand that what is the advantage and disadvantage of each of these tools. Now, what is the advantage between using visual analog scale and numeric pain rating scale? Between these two, which one do you think will have more advantage? Is it the VAS or the NRS?
The VAS.
VAS?
Yes, sir.
So why do you think it's going to be more advantageous?
Because you can draw it using ruler and ask the patient to point to the place where the pain is worst or is least.
So what about the numeric pain rating scale? I'm trying to
What's
ask
the difference between the two? I need you to explain more.
I did explain it before, but maybe you guys were not paying attention. I told you that the visual analog scale has to go under a paper and pencil tool. You will have to draw a line which is 0 to 10 centimeter line, or calculated as 100 millimeter points. And then the patient has to use a pencil or biro to tell you this is tick the line. When that line is ticked, you now take the ruler to measure between the 0 point and where the patient has ticked. That is a VAS. While the pain rating scale, while the pain rating scale is showing you that you are only asking the patient if he has a pain between 0 and 10. Where will you put the pain? The patient will just tell you verbally. So here I'm asking you this question: which is more advantageous between the VAS and the numeric pain rating scale?
Yes, sir.
The numeric.
Yes, sir.
The numeric pain rating scale.
Sir,
Yes,
I
sir.
go for the VAS.
Yes. I think the numeric, sir.
If you are for the VAS, you need to tell me why do you think the VAS is more advantageous than the pain rating scale?
The numeric pain rating scale seems more advantageous because it's easier to use.
Administer?
Yes, it's easier to administer and it doesn't need any equipment.
Okay, so the VAS. So you mean the paper and pencil equipment can be cumbersome?
No.
No, sir.
Me, I go for
No,
the
sir,
VAS.
but
You move for the VAS. You need to tell us why you have moved for the VAS.
Sir, because the VAS is more specific, you can ask the patient to find the number rating from 0 to 10, while the numeric pair rating scales is just like the patient can guess. This is so point where the pain is.
Okay, so for you, you feel the MPRS, the patient can just guess to say something which is not even what he means?
Yes, sir.
Okay. So I don't know, most of us, we now understand that you need to look at the advantage and disadvantage of any of this outcome measure you want to use. Now you also need to see the clinical utility, just like what the lady said, that it is much more easier, it is faster to administer, and there is a likelihood that you don't need any tool. In fact, this paper and pencil tool, you can forget it. You may not have it at that time, and you want to rate the patient. You get my point? So these are some reasons, but we should know that the psychometric property, that is the validity and reliability of a tool, and the ability of that tool to detect minimal clinical importance is one of the reasons why you should choose one tool over the other. And so what I'm saying here is the VAS is considered more clinically valid than the MPRS. The validity is seen in the fact that when you ask the patient to mark the point, he will consciously be using his pain limit to mark where that thing is. And then you will have to measure. That gives you both the patient and the evaluate the clinician to also be, yes, to all be conscious of what they were doing. So for the MPRS, the patient can just want to say 3 and he says 8. But since it's subjective, you just have to write what the patient says. But when the patient is looking at the mark and writing, he's less likely to make mistakes like that. So that's why the VAS is the standard, the gold standard for rating pain in adults. So for research purposes, please, you always try to use VAS than NPRS. NPRS can give you a quick information about the pain intensity level, especially during bedside clinical work down, during bedside teaching and all that. You can easily use the NPRS to rate the pain. I hope you understand this now. Can we move forward?
Yes, sir.
Now let's also look at the functional disability measures. I hope we'll have more time, maybe after this, in another class where we'll only come to do the case presentation, practical oriented assessment and evaluation as well as management of a low back pain patient. Most times when we make presentation and it looks more of abstract, it makes the understanding much more difficult. But I hope the organizers will have to create another time where we will have to do a practical oriented assessment and usage of the outcome measures. So we have to put it into clinical use during our assessment and management of the patient. So let's look at the functional disability measures. Under this, one of the gold standard is the ODI. The ODI means Oswestry Disability Index. It takes about 14 domains to be able to tell you how much a patient is able to do his activities for daily living. The more the patient is able to do the activity, the better for the patient. And then the higher the score, the less the disability. So I do this one too. I hope we'll be able to demonstrate its use. So we'll present one of the tools just for us to know that the ODI, as well as the RMDQ, the Roland Morris Disability Questionnaire, they are all questionnaires, okay? And then it means when you are assessing your patient, you may not be able to do all assessment in one point. You may assess for pain and some few things today. When the patient comes back, we assess for another thing. Otherwise, the session will be too tiring for the patient, and you may not get most of the information as you require. So the assessment should be a continuous thing, not just a one point that we have assessed the patient and that's all. Because that's what we do in our clinical situation. But I hope we'll be able to get something much more as we move. We should be able to pay attention. Sincerely, if you're able to get a good assessment and use your outcome measure properly, you'll be able to identify what is the real treatment you will give to this patient, and you'll be able to tell if your treatment is really working or is not working. I said when you assess for disability, you should be able to compare the scoring system and the ability of that tool to detect a small change. That is, if I treated my patient, and if that tool cannot detect that, it can change from pain, let's say pain 6 to pain 5, then it means that tool is not really clinically useful for you. For instance, the tool will not be able to capture a change until you have been able to change between 2 to 4 points. So this makes it a very difficult tool. I'm beginning to talk about this because if you use Oswestry Disability Index, you'll find out that the questions are asking about 4 different questions in each domain or each item. So if I cannot change from, I can do it, I cannot do it, I barely do it, I hardly do it, and things like that, you find it difficult that questionnaire will detect where your patient is changing from one level to another. So please, we will give a brief demonstration and example from all these ones I've been talking about. Let's look at when we want to do our psychosocial screening. I said during psychosocial screening, you need some tools. One of the commonest tools we use in our day-to-day clinic is what we call the FABQ. That is the Fear Avoidance Belief Questionnaire. The Fear Avoidance Belief Questionnaire is divided into 2. There are 2 parts. You have fear avoidance belief for physical activity, and then you have fear avoidance belief for work. Some people, their fear is that if they go back to work, their problem will come up again. Some their fear is if I engage in any physical activity, do my house chores or do a little work, the thing can come back. So you need to assess for all that. So we'll see how it is. We also need a questionnaire that you call the PCS. The PCS is the pain catastrophizing scale. This scale is able to rate. Okay.
Me, I don't mind.
Francisca, your radio or your audio is on. Please mute it. Thank you. So I said, the PCS is able to identify if these individuals have a fear that this pain is going to be heightened. That is, there is a fear that this pain is going to continue to increase to a level that he or she may not be able to bear. So we need to use the PCS to know if the patient has a risk of any psychosocial or psychological problems. Of course, the PCS can also be used to assess if the pain, the patient's low back pain, is as a cause of the psychosocial factor. Another scale we need to use is what we call the start back. The start back tool is what you use to categorize your patient into 3 or 4. The first category is when the patient does not even require any treatment. All you need is just to tell the patient, you are okay, this is just a muscle strain. You know, you assure the patient after screening that he doesn't need anything, he should just go take some rest and do some few things, he will be fine. So that's the level 1 of the screening tool. You have the screening tool level 2 that will tell you, okay, this patient will require some gentle and graded activity, will require some use of modality to reduce the pain and increase function, and so on and so forth. And it's also going to tell you the prognosis that since this is level 2, this is what you should give. And of course, this is how long you should give. And then the patient will be fine practically. So the start back tool is screen the patient, and then it tailors the patient to the treatment he needs while giving you an assurance of the prognosis. Of course, all these tools that we use for psychosocial screening are all supposed to be tailored toward the psychosocial treatment model or treatment approach. So we should understand that our psychosocial screening tools should be able to carry out most of the activities that will help the patient resume their day-to-day life. Okay, so it means your psychosocial screening tools should also have the ability to detect if the patient has a risk of a psychological problem or if the cause of the problem is coming from a psychosocial factor. So these are all important. We pay attention. So we're going to do that hopefully as we move. Of course, we have the quality of life questionnaire or measures. We need, if a patient presents with low back pain, basically one of their factors or domain that is being affected is their quality of life. You know, quality of life is what tells you both the mental well-being, physical well-being, and social well-being all together. It puts all these 3 domains together to tell you, is this patient physically fine? Is the patient mentally okay? Or is the patient socially okay? So you will be able to see when you use the SF36 or SF12. Now we're going to present both of them. This is the short form 36, while this is the short form is the 12, while the long version is the 36. Of course, we have the European Quality of Life Questionnaire, the 5D. We want to see how to apply them in chronic low back pain cases. Of course, not just in chronic low back pain, of course, even in acute low back pain, it can all still be relevant. So we should know that these domains are very, very important during assessment and management of non-specific low back pain. Another domain we should pay attention is what you call the goal-oriented measures. In goal-oriented measure is you want to treat the patient. Your patient is the major stakeholder in the treatment model. If not for the patient, we won't be doing the treatment. So you should not treat what you think the patient wants. You should also find out from the patient what do they need to be treated in all of their conditions. So we talk about the patient-specific goal. So you have this PSFS scale. It's the patient-specific functional scale. It tries to assess what does the patient prefer to be taken care of in their situation. So you'll be able to get this skill and use them to see that this, in the whole of this scenario, maybe the patient concern is ability to return to work. You know, if that's their concern, you will have to put all your goal and treatment plan to return patients back to work. So that's one of the goals you want to achieve. The goal-oriented measure also encourages patient-centered care. Because if I have 2 patients or 3 patients, if patient 1 says our goal is that she just wants to be able to cook for her husband, and the second person said, no, her goal is to be able to drive to work. But whenever she enters a car, she cannot drive. So you can see that every person has what? Different goals. So it means my treatment approach will be different for what? For the 3 of them. So therefore, we should know that it is goal-oriented. Okay? So how do we now choose the right outcome measures when we're trying to pick an outcome for all these domains? I mentioned to us that there are different outcomes for each domain. For pain, already we mentioned about 3 or 4. For functional disability, we have also mentioned about 2, 3. For the social, we have mentioned, so there are many. How do you choose which one is better? We say the first right choice to make is to ensure where are you looking at the problem. Is it at the assessment when I'm using, was it when the patient is having an acute problem, or is it a chronic problem? If it's acute, you know when you should use this, while if it's chronic, you know when you should use the other one. Of course, we should also know which patient are we using what for. Know your patient demographic. How old is the patient? I mentioned that you cannot use VAS for a child of 2 years. For the same thing you're going to use for somebody who is 30 or 40. So you must know the patient demographics. And of course, you should know, for instance, if you're using the Oxford Disability Index, the ODI. In the ODI, there's a domain that talks about sexuality. Now, if I come to a culturally sensitive people, you know, there are things I should not ask. So therefore, I may not want to use the ODI for such type of population. Rather, I will use maybe the RMDQ, who is not talking about reproduction and all that. Do you understand? So these are different things we need to put. And of course, the clinical setting. If in your clinic, you are a busy type, in Kano, there's a clinic, there's an activity monitor. I don't know if you guys have heard about it. It is one of the most famous hospitals in Kano, first built hospital, where the Oyinbo people work. Now, this is a clinic that can have maybe like 100 patients in a day, all of them requiring physiotherapy service. Do you think we'll be able to use all these questionnaires for such patients? Is it possible?
No, it is not.
So what do we do? Does it mean we're not going to use outcome measure to treat the patient and assess them? Or what do we do then?
We look for that is very short and concise.
So we're supposed to use something that is much more a shorter version, or something that we can easily do within a few minutes, and we'll be able to get some information about the patient. Okay, so we may not be able to use maybe long versions of questionnaires. We may not be able to use maybe the standard questionnaire, but at least we must use something to quantify the problem and also see the outcome. I'm just saying these are some of the issues that we're going to be using our clinical reasoning to debate on how do I choose the right outcome measure for the specific situation. Of course, your time constraint. If you don't have the time, how do you also do that? Is it possible that you're running a clinic and you don't have the time? What do we mean by time constraint? What do we mean? That somebody can have time constraint in their clinic?
When there are several patients on the queue and you are pressed for time and some of them are getting anxious because they've left.
Exactly. When you have a queue of patients, waiting for a cubicle, and then you entered with just one patient because you're trying to do all the standardized tools, the patient will not come out. The next thing that everybody will start agitation and you create chaos at that clinic. Okay? So when there is a time constraint that I cannot keep one patient for more than 30 minutes or 1 hour, it means I will have to use something shorter and faster. Okay? Now, we also need to talk about the psychosocial red flags, not just the red flag, because when it comes to psychosocial, it becomes the blue and yellow flags. Have you heard about the blue flag? Have we heard about yellow or blue flag?
Yes.
So what's the yellow flag?
Sir.
What's the yellow flag? And somebody give us the yellow flag.
Is it those that have psychiatric conditions? Okay, that one is orange.
Yes, the orange flag, all yellow flag, those are the psychosocial problems.
So in yellow flags, with yellow flags, you have to tread with caution.
Exactly, but what are those yellow flags indicating?
So it means you can go ahead and manage the patient, but you have to be observant.
No, it's a questionnaire that has to evaluate for some domains. Yellow flags, they evaluate for your psychological domain in terms of depression, anxiety, expectations, and all that. While the blue flag, it's all about your job. How does the pain interact with your work? Okay, so we're going to demonstrate them. I will see how we use them for the assessment. All right. Sorry, Dr. Jibris.
So what about orange flag?
The orange flag is also part of the yellow flag.
Oh, okay.
Yes. Dr. Sambani, please. We need you to come up. Are we going to have a break and come
Yes,
back, or
Prof.
how do we go?
When do you want your break, Prof?
By one.
Now?
This is one. Yes.
Okay. 1, 2.
But let me quickly round up this slide, and then we'll come back to a new one when we come back. So I said we should be able to know, I want to choose the right outcome measures, and of course, interpreting the scores and the minimum clinical change. So we will see that, when you choose a tool, you need to know what is the MCID. MCID means minimal clinical importance detected. Can that tool detect a minimal clinical importance? Yes. If it can, then that tool should be used. Why does it matter? It matters because you have used a lot of effort in trying to manage the patient. And if that tool cannot detect that changes are going on, then it means clinically that tool should not be used, because you may stop the treatment thinking the patient is not benefiting. Meanwhile, the patient is benefiting, but the tool cannot detect the benefit at that point. Okay? So you need to see that. Like I said, example, ODI score change over 6 weeks. Now, if ODI score cannot change in 1 week, it means you cannot be using the ODI at an acute stage. That's what it means. So you have to understand that. the role of that tool in treatment and planning and discharge decisions. We should know that what is the role of the tool. If I take a tool and the tool cannot tell me that, as long as pain is now maybe 3, which means my pain is mild, or 2, it means I can now discharge my patient to continue coming maybe once in a week, okay, or once in 2 weeks, because the tool have detected that pain has gone from severe to mild. So these are things we're talking about. And lastly, we should learn how to integrate whatever outcome we have done into practice. And this is where we'll talk about when do we administer the tool. We should know at pre-intervention, the moment you see your patient, try to do assessment, evaluate, and record all these measurements. As you're doing the treatment, I said during treatment, of course, you have treated the patient 5 to 10 sessions, collect data again, write out this data, and then at the end, after you've treated the patient, you do that. You now analyze, you see that clinicians are supposed to make publications more than academicians. The academicians are just publishing because it's required in their promotion. But most academicians don't have access to the patient. Clinicians are the ones seeing the patient. So we clinicians are supposed to write more than even academicians. And that's what you see abroad. If you go to the UK, the US, it's the clinicians that make publication more than the academicians. Because the academicians don't have access to patients. Okay? So please, it's very important that we try to use both paper and digital format. That is, either if you don't have the questionnaires, you should use the soft copies, maybe in your system, and then you make sure that you document and then you save them. Okay? Because at the end of the day, you see that you have a lot of data, and those late data can be used for reimbursement. Imagine that the management come to physiotherapy and said, you guys have not been working. You cannot say we are working by virtue of the amount. You have to bring out data to show that you have been working. If your HOD comes to the department today and say, how many patients are you using? You said 3 patients. You will say, let me see your documentation. What did you write? And you just saw that you saw 1 patient, you say, continue management. What did you continue? You didn't say what you've seen. You didn't say anything about the patient. So all those things are very, very important. So please, ladies and gentlemen, we will try to finish up at this moment, and then we come back and see the outcome measures, how to use them. And then there's a common pitfalls we should try to avoid. We should stop relying on only one specific measure. Sometimes the outcome measure can be faulty or could have been updated, and if we don't know, you'll be using it not knowing that it is not useful. So I say we should stop over-reliance on one only measure. And of course, we should not ignore psychosocial factors. The yellow flag, blue flags, we should always use them. And we should know that until we use this questionnaire, our outcome measures often, we'll never get used to them. So please, we should always go back and see the questionnaire. It will help us to avoid failures. So lastly, I said we must use our clinical reasoning and decision making while using the outcome measures. You will not say because the pain now has moved to 3, and that 3, in the categorization of pain intensity, 3 means mild pain. Now, if a patient came to you with concern, and you measured the pain before, and the pain has changed between 4 and 3, is there any significant change between 4 and 3? Is there a significant change between 4 and 3? Yes. Well, the answer will be no. There is no any significant change. So you cannot just say because the thing is now at 3, you abandon the patient. No. So that's why they say we should use our clinical reasoning. Of course, the tool have shown this, but clinically, what are you seeing in the patient? How do you think that your patient is doing? You must use your clinical reasoning. You don't just depend that, okay, this is what the outcome has said, and that's all. No, we should do that. And of course, we should use clinical prediction rules. That is, if I have a patient with back issue and I use exercise, we know that exercise cannot be very effective until and unless you have used it for at least 6 weeks, 3 times in a week for 6 weeks. In most of our clinic, we give a patient once in a week or once in 2 weeks. How can that be useful? So we must learn how to use that, what is evidence-based. And of course, we now need to adjust our plans based on the response we are getting from the patient. So please let me allow us to go and rest. In how many minutes are we coming back? Is it 1 hour, Dr. Samani?
Yeah.
1 hour ago? Are we coming back by 2?
Yes, I think it's okay.
Okay, thank you very much. We'll come back by
Yeah.
2. So guys, any question before we go? Or we can hold on when we come back?
We can hold it until we come back.
All right, thank you.
You're welcome.
Thank you, sir.
wallahi na gaji ne wallahi ina so ne dan huta kaɗan na haɗa azar la'asar sai in tafi insha Allah na gama insha Allah amin na gode الله أكبر لا إله إلا الله الله أكبر الله أكبر الله 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 أكبر الله الله أكبر الله الله أكبر. الله أكبر. Assalamu alaikum. Inshallah. Sai kuma wata rana inshallah. Na gode.
Good afternoon, everybody. Are we back? It's quite unfortunate too from my side. The person I asked to get me my lunch is yet to be back. But never.
Sorry.
We can still continue. Perhaps maybe when they come in, we just take another short break for me to have lunch.
Yeah, that's necessary.
So I think we should invite colleagues. Dr. Jibril Samani, are you there? Hello, Dr. Samani. I don't know, I thought 1 hour would be more than enough for break.
It's never enough.
and this is the point where the practical application of what we've been saying since morning comes in. So this is where it really matters most. So I really want us to come around. Please, if you know any of your colleagues that we started together, you can let them know that the session has started. Let's join. So while we wait for them, I think we should connect the slides. This is my slide. Okay, good. Is the slide, can we see my slide? Is it on? Francisca, can you see my slide?
I'm coming, sir.
Okay.
Yeah, I can see it.
Okay. So is it changing?
Yeah.
Okay, good. I think we stopped somewhere here, interpretation. Yes, we stopped here, so we quickly go into the outcome measures. So let's see, can we still give them another 2-3 minutes? When it's 2:15, we just commence. Give them another 2-3 minutes because the organizer is also still having his break.
Oh, okay.
So he's still not around. I was hoping Dr. Samani too is done. Hello, Dr. Samani, are you there? He's just connected, but he's not there as well. He's with us in spirit.
Good afternoon, sir.
Yes, good afternoon. So we can start gradual interaction, informal interaction before the formal one will commence. If you have any question or something you want to talk about before the session starts, you are free to come up. So feel free, you can just come up with any discussion based on what we have been talking about since.
Hello, good afternoon.
Yes, good afternoon.
Can you expatiate on the MCID? That is.
Yes, MCID. MCID means the minimal clinical important difference. So if a tool cannot detect it, that's the reason why I'm still going back to also demonstrate how these tools differ. So I'm going to start with pain intensity, and I will show you the scales, how they differ. Now, the MCID is to be able to show which one can pick up the minimal clinical change. Now, if you use VAS, VAS has the ability to pick up a change between 1 to 2 centimeters. But when you use MPRS cannot pick up until that change is above two differences. Okay, so but between 1 and 2, VAS can pick up the difference. but MPRS can only pick up 2 difference points. So we'll see it as I move into the slide this session. So please, Olademo Folashade, please, your hands is up. Can you speak? Folashade, did you raise your hand and went out again? Okay. Well, I think it's just 2:15 as we have agreed. So I'm going to be showing this aspect. Folashade, if you are there, please you bring down your hand so that it's not be calling my attention towards it again. So we have mentioned earlier that we have various pain scales we can use to assess pain intensity. And among them is the visual analog scale, the numeric pain rating scale, the face pain scale. I mentioned that the use is that it gives us a quick assessment of pain severity. So that's why we use the pain scales. We want to know how severe is this pain. And the interpretation is that VAS is able to give us an MCID that is between 1 to 2 centimeter, that is 10 to 20 millimeter. If you are using a 100 millimeter ruler, which is the same as a 10 centimeter ruler. So you can see that your VAS can catch 1 to 2 centimeter change. But the MPRS can only catch a 2-point change. So what's the difference? Let's look at the images. Yeah, can you see my image? Can you see the slide? Yeah.
Yes.
Now look at the MPRS. It's the numeric rating scale. That's A. The B is the verbal rating scale. While the C is the visual analog scale, and B is the face scale. Now, what's the difference here? Who can tell me what differs in all these scales? And that's the reason why I said we need to come up with this practical aspect to see how these changes occur. Don't forget, I mentioned to you that visual analog scale is you're going to do a 0 to 10 centimeter on a paper. And that individual must have to mark on the paper, then you will measure. Do we remember that? So this is 0 to 10 centimeters, where 0 means no pain, and the maximum pain the patient ever felt is 10. So you give the patient this to mark on a paper where the scale is drawn. So when you mark it, you measure that point. That's what is called the visual analog scale. Now, the numeric rating scale, you don't have to draw a paper, but you need to tell the patient between 0 to 10 means this is the pain, you know, and then this pain can be rated as 0, no pain. In the middle, where you have moderate pain, you know, it falls between 4 and 5, or 5 and 6. It's not even up to 6. And then when you have 8 to 10, they say it's an unbearable pain. The patient tried to rate the pain based on these numbers. While the verbal rating scale is that the patient is told you have a no pain, mild pain, moderate pain, severe pain, very severe pain, and then unbearable pain. Where do you think the pain is at this point? So it depends on how that individual understands and interacts with this before they're able to rate it for you. While the face scale is about look at the grimaces. The 0 means the patient is happy, is laughing, the pain is not bothersome. While at 5, you can see with tears and crying, the patient is suffering, and that self is an unbearable pain. You can also see that it's based on subjectivity, but we're trying to put some objectivity in this scale. Now, when you look at this scale, you will have to understand that the situation of the scale is showing us that there is a change in which one can detect and the other cannot detect. The visual analog scale will be able to detect any change between 0 and 1, 1 and 2, 2 and 3, and so forth. While the numeric pain scale has been shown that it has to go through 2 points. Look at between 0 and 4. You can see that it has to go about 2-point changes before it detect any meaningful change. Because you have about 1, 2, 3, 4 before you can see that there is a change. I don't know if you're understanding me. Between no pain and moderate pain, look at the amount of value you have before you can get to a change. So this is something that it's quite difficult for us to see that if you are using this change, this is where this is more important than the other, and that's what you call the MCID. That is the minimal clinical, important difference. That clinical important difference is what you want the tool to be able to detect. And if you see the face scale, it can only give you from 0 to 5. And now it depends on how you're able to assess the face of the patient. So you can see that this one can only usually be used in children. And then in children, a child can even be scared of you and will make you cry, or scared of your white shirt or white coat and make the patient cry than even the pain. So you can see that all this cannot give you minimal change than the VAS. So this is just what we are talking about. Now, apart from pain intensity, we mentioned we also have other physical examination measures we need to do, like the range of motion test. The ROM can be assessed using goniometry. You can use the muzzle. Of course, you have the manual muzzle testing where you try to assess the muzzle power. Generally, we use the Oxford muzzle grading system where power 0 is no flicker and power 5 is the normal muzzle power. So I believe all these are things we all know. And then, of course, we talk about the straight leg raise test. We are coming to talk about in full content about the SLR when we're doing our next, if we have any other opportunity, talk about how we do investigation and how we assess patients with low back pain. I hope we still have opportunity some other time. So we're going to talk about that generally. So I said the physical examination, generally what it does is to be able to help you as a clinician detect any impairment in that patient. So it means if you do a range of motion or you do a muscle power testing or SLR, you should be able to know if there are any issues with asymmetry or the production of symptoms, which is significant. It means if there is one limb is longer than the other, you can see there's a limb length discrepancy. You will know what to do. If one muscle power is greater than the other, you know there is an impairment, you know what to do. If the range of motion is maybe flexion of the spine is, it is reduced than the extension, all these can tell you what to do next. So I believe these are the reasons why we usually do all our testing. Apart from this, we have the functional disability test where I talked about the use of ODI. The ODI has 10 sections. And what it does is that it assesses the functional limitations. That is, what are those things that you as an individual with low back pain cannot do? So this is what we do when we use the ODI, and its scoring is between 0 to 20%. When you have a 0 to 20%, it means your disability is minimal. And then when you have greater than that, it shows that the disability is worse. So you can see that any disability you have that is above what do you call it, 60% or 40 to 60%, it demonstrates that disability is significant. Okay, so you see 0 to 20 is minimal, 20 to 21 to 40 is moderate, as well as 40 to 60 is said to be severe disability. Now, The minimal clinical important difference that this ODI can detect is up to 10 points. That is, when there's a 10-point difference between this percent to that percent, it will be able to detect it easily. So that's why ODI has a better standardization in its usage than when it's RMDQ. This is a sample of an ODI questionnaire. I don't know if you can read it from there. It has 10 sections. The first section is about pain intensity. It asks, the pain comes and goes every time and is mild. It talks about, another section that is personal care. It mentions about lifting. So it goes on and on like that. So you will see that the section there are 10, and that is the scoring at the end of the questionnaire that says between 0 to 10 is a minimal disability, 11 to 20 is a moderate disability, 21 to 30 is severe disability, and it goes like that. At this point, I want you to tell me, what do we mean by it can change, I can detect a change between at a 0 to 10 points? What do we mean by that? Please, excuse me, are we seeing the questionnaire the way it's showing on my system? You see it? Is it clear?
Yes, yes.
Okay, I don't know how big I can open it. Can you, is it better this way?
Okay, yeah.
Because the more I expand it, the more some of the alphabets may be.
The 10K, if I would talk.
Yes, please go ahead.
That is the interval scale is within the 10 range. That is, yeah, that's just it.
Between what?
I mean the interval scale is within the 10 range difference. Yeah.
Okay, you're saying the 0 to 5 points is the 10 points we are talking about. Is that what you mean?
The interval scale within that ODI is 10 point.
Yeah, that's 0 to 5. That's what you meant, right?
Yeah.
Oh. Of course, that's what it is. It's why it's showing you that it can detect any change between one section to the other. Do you understand? But I want us to look at those sections, those 10 sections. Do they really capture disability as related to back pain? Please look at it. We've seen it. The 10 sections.
Yes, sir, we can see.
So what can you say about the different sections? Did they really capture the disability as relates to low back pain?
Yeah, quite all right. They capture disabilities.
Okay. Now I want us to look at the relationship between section 1 and section 10. What can you say about the two sections? Pain intensity and then changing degree of pain.
Can you put it up? We don't see the section 10 here on the screen.
You see it now? Is it there?
Yeah.
You see it. Nobody is giving us any information.
Section 1 again.
I think both information on section 1 and section 10 are correlated.
Sir, section 1 is basically talking about the nature of the pain at present, and section 10, it's like a comparison between past and present.
Exactly. This is what I want us to look about. Now, which of the present, which of the past tense are we talking about? Because if I'm accepting this patient as at the point of entry, this is when I'm meeting the patient for the first time. And I'm using the ODI to quantify the disability of this patient. And I look at section 1 and section 10. I need to get the relationship. Now, imagine that the patient tells me, when I was asking about the pain intensity, it's called, the pain comes and go and is very mild. You know, that's called 0. Is that true? Yes. Now, at the section 10, is telling me my pain is rapidly worsening. What information am I going to deduct from that patient? So this is where I'm talking about the clinical reasoning. Let's think about it, please. In section 1, he told you that the first score is the pain comes and goes and is very mild, 0. And now in section 10, he takes a 5. He scored 5, that the pain is rapidly worsening. So how are you going to talk about this patient? Please, somebody did score.
So is it possible that the the frequency is going up? Maybe initially it was maybe twice or thrice a day that it comes, and then because it's getting worse, maybe it's not coming up about 7 times a day. It's becoming more.
Yeah, but the point I'm trying to make here is It's how do you interact with that patient that you are meeting him for the first time, you are on the same table, you're assessing the patient, he ticked for section 1, the first one is 0, and then for section 10, in that same moment, is telling you 5.
So it's actually confusing.
Exactly.
But maybe, so maybe the patient doesn't really understand the questions. Maybe you have to explain further.
Beautiful. So this is the point I'm going, that you don't depend on the questionnaire alone. You must need to interact with the patient deeply, because there are silent information that will come out of it. When the patient tells you, my pain is mild, and it is rapidly increasing, there must be something you need to deduce. Do you understand that? We need to deduce now from other scores. Because if this patient tells you that in section 1 is 0, section 2 is 0, section 3 is 0, but it tells you at section 4 is 5, how would you interact with this patient? Where will be your problem? So it means we need to understand the interpretation and the meaning of this questionnaire on what you're asking about the patient. Some patient can be having delirium. Some patient could not, perhaps they are confused. So you must know the main state of intelligence of the patient. You know, is attention. Does the patient have some kind of attention deficit? Is the patient having a good cognitive situation? If the patient may not be oriented in TPP, and you may not know. So this is why I am bringing up this, for us to understand how these questionnaires could also be faulty if you are not paying attention. Do you understand that now? Are we okay with this? Can we move forward, or we need to make some explanation more here?
Let's move forward.
Okay, great. So we move to another questionnaire we use for the low back, is what you call the Roland Morris Disability Questionnaire. In the RMDQ, we have 24 statements. But what it does is that it's used to assess if the patient have mild to moderate disability. That is, when the patient have a severe disability, the questionnaire may not be able to capture it. So it means if you're trying to do a research, you must be very careful your group of patients you are using, so that you don't use a questionnaire that will not capture what you are looking for. And in RMDQ, it says the higher the score, okay, then the greater the disability. While for ODI, the higher the score, right? That the higher percentage you go, the lower the percentage, the lower the disability. So here we look at, it has MCID of 4 to 5 points. Okay, so let's see the questionnaire, what it looks like. This is an RMDQ. Unfortunately, this is RMDQ which is not in English. I was supposed to convert it and I didn't even see how I missed the conversion. But there's an English version. Ja and nay is yes or no. So please, I'm going to put up the English version as we move. Or perhaps you just give me like 5 minutes to bring it up. Just 1 minute, I will bring it up now. I have it in my system. This is the English version. Can we see it?
Yes, sir, we can see.
There are 24 questions, and what you're expected to do is to click yes or no. For instance, the first question says, I stay at home most of the time because of my back pain. You know? So is it yes or no? I change position frequently to try to get my back comfortable. I walk more slowly than usual. So look at this and see, how do we quantify it? Is there a difference between question 1 and question 2?
Yes, there is difference.
What's the difference?
And the first one is that the patient restricted at home. That is the back pain confirm him or her at home. But the
Yes.
second one is that changing positions has to do with whether you either lie down or sit down, or assume sitting positions, or lying on the right side or left side, or lying prone or supine. That one has to do, yeah.
Exactly. Now the problem is, what is the difference in number, in magnitude, between the change of I stay at home because of my back and I change position? Do you get the question?
I think it's the severity of the pain.
Yes, here, where's the severity between the first and the second question?
Okay, the first one is more severe, that it makes the person unable to live. But the second one, the pain is much, but with the change of position, there might be a degree of relief.
Exactly, but we're trying to quantify. What do you think? How many value? Do you think the change is going to be between 2 and 3 points or 3 and 4 points? What's change? You remember in the ODI, we said you have a 10-point change, right?
Yes.
So here, what point number of change can we quantify this?
Okay, I can't really place it somewhere.
You can have an idea. Actually, because there is no idea, I'm just trying to bring it up to your attention that this is why it's difficult, especially in research-based studies. You want to talk about how the disability of Mr. AA has changed between I stay at home every day and I change my position frequently. So what is the magnitude of that change? You know, by your intuition, you just mentioned to us that you think it's the severity of the pain. That the first question means the pain is so severe that it has what? Confined this patient to sitting at home. But this one just means changing position, maybe from sitting to standing, standing to sitting, and so on and so forth. So you feel the pain in one is higher than the pain in two. And that's why the disability one will be more than two. So we're trying to see, can we quantify what change has taken place between 1 and 2? So we couldn't. And that is the reason why we're looking at all these questions, that before you can see a significant change, there would have been a 3 to 4 point change in question before you will be able to capture it. And that's why it tells you this questionnaire cannot capture a very severe problem to know how the change will occur. Okay? So these are some questionnaires you could use. So please, as we get the presentation from the organizers, let's try to use these questionnaires as often as possible. I'm going to come up with a clinical case scenario that we'll do before we leave today. So let's look at this quickly. Another item we normally assess, we have mentioned this, is the patient-specific function scale. I said this scale identifies 3 to 5 activities that every patient or every individual would like to do. Okay? So we use this questionnaire usually to track the progress of this patient based on what they really want to do as a function of their day-to-day activity. So majorly you're going to assess the patient based on, can you perform that activity? If they can perform the activity, they score up to 10 points. And if they cannot perform the activity, they score 0 points. But between the 0 and the 10, there are changes it can only detect is between, if you can do something between 0 to 2 or 0 to 3. So we'll see unable to do, slightly unable to do, likely unable. So we'll see those changes as we move into the questionnaire. This is a sample of the questionnaire. In this questionnaire, you see points to one number, 0 to 10, where 0 means unable to perform the activity and 10 means able to perform the activity. What do you guys think this activity should be? Any idea? What do you think this activity should be?
For instance, ADLs, activities of daily living.
Like what?
Cannot climb stairs.
Activities of daily living.
Okay. Who is speaking? Is it Enahoro or Dayo?
Activities of daily living.
Like what? Specify, because we have to specify what we're
Like
the
taking care of household.
Like baking.
For the ladies,
Exactly.
cooking,
Excuse me. You see, you
going to
cannot
the
take a
market.
lump sum. Hold on. You can't take a lump sum of activity. Like I mentioned, I say it has to be activity specified. And it should be specific to that patient. Now, for instance, a patient with shoulder problem will have an activity that is specific to him than a patient with low back pain. Do you understand? Now, for low back pain patients, one of the commonest activity they like doing is walking. That's one. bathing, hygiene. Some activity will be like somebody who is a pastor or an imam. His major point will not be okay is the prayer position. He cannot bend his back to pray, for instance. So all these are patient specific. So if you mention that, number one, patient cannot bathe themselves. Bathing, that's hygiene. Since the patient cannot bathe himself, what are you going to give him? Is it 0 or 10? So that depends on what you are able to see. If he's unable to do it completely, it's 0. Okay? And then you have other values between 0 to 10. And that's why they say this scale can only detect a change that comes up between 0 to 2, or 0 to 3. But 0 to 1, 1 to 2, 2 to 3 cannot be detected. I hope we're getting it like that. I need your permission to move ahead. If we are not getting it, we need to stop and discuss.
We are getting it.
And we have the previous slide.
It's somehow confusing.
So
let's move to this previous slide 52, please.
Slide 52.
Yeah.
Okay.
That we see.
Yeah, this point.
Yeah.
Okay. So I said the MCID, that is the minimal clinical important difference this tool can detect, is a difference between 2 to 3 points. It means it cannot detect between 0 and 1. Okay, it can only detect between 0 to 2. In fact, 0 to 2 is 1 point. So it can only detect between 0 to 3. Okay, it's not saying it can detect between 0.2 to 3. No, it can only 2 points. So 0, 1 is a 2 point. 1 to 3 is 2 points. So those are the things it's saying it can detect. Mr. Alue,
Excuse me, sir.
Yes.
Sir, I have a question about the MCID.
Yes.
I previously thought the MCID, it indicates that that's the minimum point, like the difference, the new change that's required to translate into a visibly, a clinically significant change in function. For instance, if the total score of my patient...
function. Excuse me, it's not about necessary function. Okay. It's about what the tool is assessing. You can get MCID in pain intensity, not in functional whatever. You can get MCID in fear. MCID is what that tool, can it detect a change clinically? Do you understand? So the point where it can detect is what you call the MCID point.
Okay. Thank you, sir.
So it's not necessary function only. Somebody was on the line before, or Loye Day or so. Okay, can we move forward? We still need to deliberate because somebody, yes, Francisca, you said this is confusing a bit. Where is the confusion coming from? Francisca, are you okay? Can we move forward?
Yes, sir.
Yes. Guys, are we okay? Shall we move?
Yes, sir.
Right.
Yes, sir.
Yes, sir. Yes.
So let's look at some psychosocial outcome measures as well. This is like I mentioned earlier, fear avoidance belief questionnaire. It talks about your belief in fear about your physical activity or activity at work. So it is used to identify the risk of chronicity. Because if your fear is high, it means it suggests you are having a high fear avoidance in either physical activity or your work. So when you are using the FABQ, you use it to identify that this patient you are seeing today is the risk of developing chronic low back pain because it's showing high fear of what? Moving or fear of walking. So if you're able to do this, you know that the first point of treating this patient is to take away that fear if you don't take away the fear, either by education, other by whatever means, maybe cognitive behavioral therapy, then it means your patient is likely to develop chronicity. This is a sample of an FABQ questionnaire as well, you know. So the patient is expected to answer on a Likert scale, whether they completely disagree with the statement or they are not sure, they are undecided, they completely agree with this statement. The 7-point Likert scale from 0 to 6, okay? So you ask the question about the patient. How is your pain? He said, my pain was caused by physical activity. You can imagine if the patient answer 666, that physical activity means my pain was, physical activity might harm my back, did not do physical activity, cannot do physical activity. So if all this statement agrees to 6, you can imagine that this patient, there's no way he's not going to develop chronic low back pain. And you see that every type of your pathology you are doing, pathoanatomical model, or by you know, the biological model cannot help this patient because the psychological aspect is not taken care of. I'm sure most of us in clinic, we don't have that patience to use this questionnaire. Is it that we don't have access to the questionnaire, or we really do not think about using it? Gentlemen and ladies.
I think
we don't have, and then
We don't have
we
access
don't
to using
also know how
questionnaires,
to
sir.
use it and how to use it.
Yes, I thank you so much, Francisca. She's very honest with her submission. She said, number one, we don't even have access to these questionnaires. And number two, we don't have the technical know-how. We don't used to have training about how to use this questionnaire. So I want to thank the Ray consultant that it means it's a timely program we came up with to show us and demonstrate how to use these questionnaires. They are very vital, and I see no reason why we shouldn't use them. Our HODs, most of us will go and get ready to buy laser machine, TENS machine, and those things. But some of these little things that will cost little or less money, we don't pay attention to them. Okay? These are questionnaires that are readily available. We can get them online. All they need is just make photocopies, make them available in the clinic. Because if it's on the clinic table, just the way you get your X-ray form and other forms, laboratory forms, you know, you're able to pick this FABQ on your table, the VAS on your table, and all that. I'm sure we'll use them much more often than what we are doing presently. Is that true?
Yes.
You're right, sir.
Yes, sir.
Yes, it means we need to make more advocacy to ourselves, the department. We don't need to be gigantic in buying every type of shortwave diatomy and all that, because we begin to know these days that shortwave diatomy alone can never treat a patient. So why do we put about 20 million in one machine that we still need other things? Why not even equip our gym for us instead of using one money to buy only one machine? Okay, so we need to be involved at the what do you call it, at the level of decision making in budgetary allocation and use of funds. So please let's also take this as some of our duty to advocate in our various departments the need for us to have outcome and measures to be readily available on our clerking desks and tables. Yes, so you can see what all this is all about. It talks about my pain was caused by work. So the upper side is about physical activity, while the lower side between 6 to 16 is for work. So at the end of the day, you are supposed to score it. They say the scale for fear avoidance with work, which is item 6 to item 15, it tells you about this, that you should score this separately. And then the other one is about physical activity, which is item 2 to 5. Then you'll be able to score it differently. At the end of the day, you aggregate the score for you to know if the score, the fear is high or the fear is low. I've mentioned that the higher the score, the higher the risk of going into chronicity, as it indicates that there is high fear avoidance in that patient. Now, another domain we need to assess when we are doing low back pain is the pain catastrophizing issue. We know catastrophizing means, blowing the pain out of proportion, thinking that this pain, before you know it, the patient starts thinking is a cancer, So the moment the patient magnifies the pain beyond necessary proportion, it can come up with a catastrophizing situation. So there is a scale that is used to assess for pain catastrophizing, which is the PCS. The PCS is done to identify any rumination, magnification, or helplessness. Imagine the patient thinking nobody can help him out of this, the doctors cannot help, the physios cannot help, the chiropractors and every healthcare provider cannot. The patient has gone to traditional and every spiritual and feels is helpless. So this is what will lead to catastrophizing of the pain. The PCS is used to detect maladaptive pain thinking. So it is thought process, how you think about the pain is what you should be worried about. That we need to know. Are you thinking straight? Are you thinking in a wrong position about this pain? The clinician will be able to know. And the scoring says the moment you see that the patient scores beyond 30 points, it shows that there's a clinical significant situation that this patient has a catastrophizing pain. So we use this scale. This is the questionnaire. Hope this is clear. Is this clear enough?
Yes, sir.
Now, you look at it, it's also a Likert scale that tests a question and asks you, how do you think about this pain? It said, not at all, to a slight degree, to a moderate degree, to a great degree, all the time. The question starts, worry all the time whether the pain will end. Oh, what mark are you giving it here? So you can imagine the questions you have under this. There are about 11 questions. So all these questions, if you put them together, and the patient scores 30 points and above, it tells you there is a significant situation. So it means the higher the score, the higher the problem, that is the catastrophizing in that patient. So he said the first aspect of the rumination part of the question is question 8, 9, 10, and 11, why the magnification is question 6, 7, and 13, why helplessness is from question 1 to 5, and then question 12. So all these put together, if you have a total score that is greater than 30, that is greater or equal to 30, then you have a significant clinical difference. Because if you look at the response, I don't think about this pain at all. I don't do this at all. It is terrible, not at all. So you will see that you are 0, 0, 0. So if you put 1, 1, 1, it's like scoring 10 or 11. 2, 2, 2 will be like scoring 20 something. Then when you put 3, 3, 3, it's above 30, and that is significant. So this is how we calculate it. Any question here? Are we moving?
Sir.
Yes.
This question,
yes.
Would it be something that can it be used for all patients? Because I feel like if you are explaining this to some patients, the literacy, the ones they might not really understand it.
Yeah, and that is the reason why these questionnaires are generally in English. And there is a need for us to domesticate it and make it contextualized in our different languages and cultures. Do you get my point? So if you take this now, you can do what they call translation and cultural adaptation of the questionnaire. You translate it, if you are in the Southeast, maybe into Igbo language, which is very common there, and see what context does not relate to the Igbo culture, you remove it and put what will show that this is an Igbo culture in trying to express how bad you feel with a pain. Of course, you mentioned that can we use this questionnaire for other MSKs? Yes, as long as the condition comes with a pain. Don't forget, this is pain catastrophizing. We're not talking about a particular pain just in the low back. So you can use it for the neck, shoulder, knee, and other places as long as the patient is complaining of pain. Okay? Another issue Esther tried to raise is concerning the literacy level. If you're using a questionnaire like this and you feel that the patients are not literate enough, then most times what you're asked to do is to, of course, get it translated in their local dialect, and then you will be the one that will be administering the questionnaire to the patient. So these are different ways of using it. Okay? Are we happy with that?
Yes, sir. But some of the questions on this questionnaire, they are so similar.
You said they are so similar. Which part?
Like this one that says, I can't seem to keep the pain out of my mind. I keep thinking about the pain. I keep thinking about it's it's almost repetitive in different form.
You see, and that's why the language comes in. You know, I can't seem to keep it out of my mind. I keep thinking about it, how much it hurts. They are two different things, even in English. You know, this means I can't seem to forget or take the pain out of my mind, but I keep thinking how much it hurts. You see, you're worried about the severity, and then you're just like, it's constantly reminding you have pain. So, and that's why when it comes to language translation and transliteration, we will have to look at the contextual information in your local dialect. What will this translate to? Okay. So, but as in English too, these are two different things, and they want to see how much you relate or react to both. Okay. So, I think let's continue to make progress because of time. Yeah, this is the DAS questionnaire. The DAS questionnaire is about depression, anxiety, and stress. DAS, we call it the DAS 21. The 21 is on the WHO code of depression. So this questionnaire, what it does is to assess the emotional state of the individual. Okay? It tries to see what are the psychological barriers that the patient had during screening. So when we finish, you are expected to interpret, does he have a moderate or severe score? That if he has a severe or moderate score, it means it warrants referral to see a psychologist or a psychiatrist, okay? So that you don't come and bother yourself trying to treat a patient that had other problems. He's not going to be adhering to your treatment. He's not going to follow, comply and all that. So you go let them address this situation before you do your treatment. This is an example of the DAS scale. This is another version of this DAS 21. You will see it's also a Likert scale of 4. When you ask the question, it said the rating scale is as follows. 0 means did not apply to me at all. 1 means applied to me to some degree or some extent, applied to me to a considerable degree or good part of time. Or 3 means applied to me very much and most of the time. So these are the scores you are expected to put into the questionnaire. It said, I felt I was close to panic. So never, sometime, often, or always. So this is how you fill the questionnaire until you get to the end of this questionnaire. There are only 10 questions, and then you'll be able to see the higher the score, the higher the depression rate or the anxiety scale. All right. So these are the psychological variables. Let's see, do we have other variable we can use to assess for preventive aspect, just to prevent the problem? I call it preventive outcome measures. An example is the QOL start back screening tool. This QOL is a university in the UK. They developed the start back tool. And what the start back tool does is to classify patients with low back based on the risk. That is the risk of going into chronicity and the risk of having a good prognosis or otherwise. We say it is used to stratify. It is used to stratify the care, that is the stratified care approach. What it means by stratification is you will see if this group of patients are having group 1, maybe low risk, then they will classify them based on what treatment dimension or what are the interventions you should do. If they are in moderate risk, they give you, and high risk, they also classify based on what you do. And they said, if you have any patient who is already having a psychological subscale that is greater than 4, then you put those patients on high risk, and they will have to go through CBT and other psychosocial or psychological treatment. This is an example of the the start back tool. You see, they want you to think about your low back problem in the last 2 weeks. You give the response, the following questions. Question number 1 says, my back pain has spread down my legs sometime in the last 2 weeks. Do you agree or disagree? I have had pain in the shoulder or neck at some time in the last 2 weeks. I have only walked short distances because of my back pain. In the last 2 weeks, I have dressed more slowly than usual because of my back pain. Not really safe for a person with a condition like mine to be physically active. Worrying thoughts have been going through my mind a lot of the time since these last 2 weeks. I feel that my back pain is terrible and it's never going to get any better. In general, I have not enjoyed all the things I used to enjoy. Overall, how bothersome has your back pain been in the last 2-3 weeks? So the individual can say, is it not at all, it has not been bothersome, slightly, moderately, and all that. So at the end of the day, you will have your total score. Okay? And that's why they mentioned here that if you score anything greater than 4, then you're likely going to be on a high subscale. So this is how you look at this questionnaire. Okay, it helps you to see what do you need to do to prevent further escalation of the back problem. The last one I want us to see before we look at the case scenario is the Tampa scale of kinesophobia. That is the fear of movement or re-injury. Because when people have back pain, most of them have the fear that when they move, pain is likely going to come back. So the TSK is used to assess for fear of movement or fear of re-injury. It's used to prevent chronic disability. And any score that you get at the end of the day that is greater than 37 points, it means the person has a significant kinesophobia. This is also a sample of the questionnaire. Strongly disagree, and it scores between 1 to 4. There are 15 questions altogether, and then when you put the total score, you see what the patient can get. Now, ladies and gentlemen, we are going into where do we now put all these questionnaires into use. So I'm going to present a case scenario. So before we do the case, can we see if we can divide ourselves into groups? Who can help us do that? Online here, we have about 40 participants who are online presently. Can we just take ourselves into 10, a group of 10. Then some, it means we have 4 groups. So please, I need you to just indicate by raising your hand. If you are in group 1, please just show me those who are in group 1 by raising your hand. Group 1, just raise your hand. Indicate by showing you have raised your hand and the chat box, please. Group 1. I've not seen any hand coming up. Hope you can hear me. Okay, good. I can identify Abdullah Suleiman, somebody that is auto rehabilitation, Olubukola Babatunde, they are all in group 1. Yes, Francisca is in group 1. Yes, Esther is in group 1. That is 1, 2, 3, 4, 5. Okay, Esther is in group 1. Who again? Yes, how many do I have now? Okay, Dayo, my chief is also in group 1 from Rano. 1, 2, 3, 4, 5, 6, 7, 8. We have 2 more people to be in group 1. Yes. Group 1, 2 more persons. Okay, Sylvia, and 1 person more to complete group 1. Group 1. 1 more person for group 1. Are we there? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yes, Z has completed it. So please, group 1, can you bring down your hand? For those who want to be in group 2, please, group 2, bring up your hands up. Kindly note yourself in group 1, group 2, group 2. Okay, good. I've seen if anyone Mbakwe. Yes, that's the first person in group 2. Please, let's quickly do this. Babatunde is in group 2. Yes, yes, yes. Guys, are we there? Let's finish this thing quickly so that we can go after 4. Yes, Iloba Emeka is there in group 2. Please, let's finish up. Is it that we are not paying attention? We just connect and go. Some of us are not there. Okay, Enahoro is there in group 2. Yes, please. Abisola, are you there? Moji? Well, it's quite, I want it to be very, very interactive, but it seems some of us are not really paying attention. We connected and we're not close to the phone. I'm sure most of them are not close to their phones. So instead of wasting more of our time, we'll just delve into the case work and see what we can do about it. So let's just look at it in this way. Okay, this is a case presentation of a patient. I want us to see how do we apply all these outcome measures we have used in what we discussed about today. How do we apply them in a clinical scenario? So I present to you a patient, Amina Yusuf, who is 38 years old. She's a female that an administrative officer who works with the university. Her major complaint is that she's got this non-specific low back pain and has been there for the last 5 weeks. She mentioned that her pain worsens with prolonged sitting and there is no history of trauma. So for those in group 1, the question is, what are the clinical assessment domain you will want to do for this patient? What are the domains you would like to assess? Yes,
Pain
thank you so much.
intensity.
Somebody has
Pain
sent us.
intensity. Pain
Beautiful.
intensity.
Pain intensity is number 1. Thank you so much. Madam has been following us this morning. Thank you for being there.
Thank you, sir.
I'm very happy. She said we're going to do pain intensity. Now let's look at the situation. We said she complained of this pain and it worsens with prolonged sitting. How would you want to assess the pain?
Another thing we can see is whether it is acute or subacute or chronic.
So 2 weeks now.
Yes,
2 weeks.
5 weeks now is
5 weeks.
Acute. It's an acute pain. Yeah. Less than 6 weeks. Yeah.
Yes. Olubukola, they said the pain is 5 weeks.
Yeah.
So where are we keeping the 5 weeks?
Acute.
Acute stage.
Okay, so we agree it's still in an acute stage, right? So do we all agree this is still at acute stage?
No, more than
Yes, sir.
It's more than 2 weeks, sir.
Subacute.
Subacute, sir.
Subacute.
It's subacute.
All right. Thank you very much. We're all following. Yes. Now she mentioned that one of the first things she will want to assess from Mrs. Amina is her pain intensity. So who's going to do that for us? Who want to measure the pain intensity? How do you do that? Group 1 members.
So we can use VAS now, or we use a numeric pain rating scale.
I told you that you must know why you are choosing a choice of measurement.
Yes.
So which one are you choosing?
VAS. Can use VAS.
VAS. Okay. So VAS is okay. So who will tell us what you will want to tell her? Assuming I am the patient, tell me what do I do to fill in your VAS?
I don't know.
I'll tell you.
Group 1 members, you want to measure VAS now, yeah?
On a scale of.
So I will bring out the VAS scale.
Okay.
And then I will place it before her. I will tell her to, please let me know, at which point do you feel more pain, moderate pain and severe pain. You have this scale, is from 0 to 10. It's 1, 2, 3, 4, 5, 6, 7, 8 to 10. So can you just mark on the paper where I've wrote with a pencil and say just mark it, let me know where your pain is.
Group 1 members, do you agree with Madam Francisca? Group 1 members, do you agree with Madam Francisca based on her description of how to assess for pain intensity using VAS?
VAS. Group 1 speak now, help out. Polish it.
Yes.
Polish it more. If there is something.
Yes.
I think we agree. I agree with her. That's
you as an individual, you agree. Don't forget, Madam Francisca mentioned something. She said she's going to mark it 1, 2, 3 to 10. Do we do that on VAS?
No, for VAS, we are not going to use from 0. Not going to mark it 1, 2, 3, 4, 5.
It's from 0.
We ask the
Madam
patient to.
That she's using a hybrid of VAS and MPRS all together.
We'll say maybe
Excuse me, Prof.
if
We only
the
give the
minimum
pass
is
and ask the patient to talk where is the level of the pain intensity.
Exactly. All right, thank you very much. This is quite interesting. We just want us to know that these things are doable and they are accessible within our reach, okay? So we just know which one you want to do first. Now, this is the first scenario. She has agreed she's going to measure pain intensity using VAS, and this is how the VAS is going to be measured. So in this presentation, any other member of the group, where do you expect this case Madam Amina is going to drop her pain on VAS?
I think I would say, hello, Miss Amina would more likely drop her master. Pardon? No, it should be around 5 to 4.
So 4 to 5?
Yes.
No, it's more than that. Pain worsens with prolonged sitting.
It depends actually
so
on...
much, Madam Francisca. There are 2 things I want us to look in that word. Okay? There's a place where she's at rest.
Actually, it depends on where the Madam Amina, the position he assumed when we want to take the pain.
Yes.
So that's
depends on the position.
going to listen up, everybody. That's where I'm going to. As at what point are we assessing the pain? Is it at the point when our pain has worsened, or is that the pain when it has not worsened? You must differentiate. Do you get my point?
Okay.
She told you that her pain worsens with prolonged sitting. Now, assuming Mrs. Amina has come to your office and it took you like 20 minutes, 30 minutes before you start this assessment, will you be assessing her pain based on the pain has worsened, or you are assessing the pain as normal as she normally complains about it?
We assess the pain as she normally complains about it.
So it's not the worsening pain, right?
Yes.
Isn't it better to do the 2?
Okay. So this is where I want us to know there are 2 pain intensity you want to measure. It's like a patient telling you, I have pain in my back and I have pain in my buttocks. So the pain in the back is different from the radiculopathy also, or the radicular pain in the leg. So you must measure this pain separately and measure the radicular pain separately. All right?
Yes.
I don't know if we're making some sense here.
Yes, sir.
Yeah.
All right. So this is one scenario we have seen. And then I was trying to also look at, apart from the pain intensity, what else would you want to measure?
The disability, sir.
LADA.
What?
The disability. The disability.
Disability. So we call it the
activities that
functional
she cannot do, activities that was
Okay, so what would you want to use to assess the functional disability?
The ODI.
The ODI.
ODI, yes.
So we want to use the ODI. Don't forget, in the trying to use the ODI, you are also measuring a pain intensity in your section 1. And then you're also looking at the pain characteristics, how the pain is changing in section 10. Okay? So all that culminates to tell you how much the patient, what he has lost. Is it up to 10%, 20%? You will be able to see the disability loss.
Yes.
Okay. Now, in the physical examination, I say this patient, maybe we use all this. She has 6 over 10, and then 3 over 10. You can see this is what I have mentioned to you. You have 2 different pain intensities you should measure. The time her pain is worse is 6 over 10. And her best time of pain is 3 over 10. So you can see that, right? Karim Masajo, can you put off your mute your mic? Oh yeah, your baby is not giving us attention deficit. Okay, so let's look at physical examination of stamina. What would you want to assess physically?
Actually, what I will assess is one, the mobility.
Is what?
The mobility around the spine, especially the.
You see, you have to speak like a physiotherapist. When you say mobility around the spine, that is too bogus. Nobody knows where you are going in the spine. The spine takes from the cervical.
We start from her posture.
Okay, you want to assess posture?
Yes, we want to assess posture.
Okay, in assessing posture, what do you want to look at? If I ask you to assess Mrs. Amina's posture, what do you want to look at?
The shape of the spine.
You want to look at
the movement.
The shape of the spine is not the posture.
Like if you want to assess the
shoulder level,
okay, whether there is
the lordosis of the spine.
Those are measurements of low doses curvature of the spine. But we are talking about posture. Somebody said they want to assess posture.
What I will look is the position, actually the lower back, especially the pelvis. Is it like contra nutrition or the nutrition? I will look at on lateral
No,
view.
you see, all those will not give you a particular pattern of assessment. Since you want to assess for posture, all your attention should be based on asymmetry. You want to look, does this patient has a symmetrical view between the left and right side, the up and the back side, the upper and lower side, you know? So the asymmetry is taken from the head to the neck, both shoulders, the hip, the pelvis, the knees, and then the ankle and the foot. So if there is an asymmetry, that there's going to be a tilt, like a patient showing translumbal sign, okay? So all these will now be that there is an abnormal posture, and that will also strike you that the physical examination shows there are asymmetry of the spine. So from there, you can go ahead to assess what you call the you assess for apart from asymmetry, you now start assessing for the curvature of the spine. You know, you start with the Adams forward test. You want to see if this patient has what you call a functional scoliosis or a structural scoliosis. A functional scoliosis means when you're looking at the patient from behind, even though there is a curve, you know, that curve's angle, you can see it, but the moment the patient begins to flex forward, that is the forward bending, that curvature will disappear. That is called a functional scoliosis. But if the patient bends forward and the curvature still remains there, it means it's called a structural scoliosis. And structural scoliosis cannot be treated with conservative measurement. It has to go through surgery. But why the functional one can be treated with more of this physiotherapy modalities as well as exercises. All right. Having seen physical measurement, we needed to see the muscle power. We should measure.
He's happy to do when he wants to climb. Anything he will climb. He's happy to do.
Want to assess in this patient in a psychological situation? Yes, please feel free to speak. What would you want to assess in the psychological domain?
So the fear avoidance.
Exactly. Why do you think you need fear avoidance here?
Because it's related to her work.
Because we mentioned that Amina Yusuf is an administrative officer.
So, yeah, so she spends a lot of time on the chair.
Okay, she goes to work. If she's a housewife, it could have been a different scenario, okay? So apart from fear avoidance, what else would you want to assess psychologically? So this is functional domain. I said we're going to check for patient-specific function, activities in standing, carrying, and all that. Okay. These are psychological domain where we talk about the fear avoidance belief in terms of physical activity. So when you assess, you should record it. Okay. Then the work should also be recorded. Then emotional screening, we should also use the DAS, and you will know whether a patient has some anxiety or not. So in the assessment for preventive domain, I'm just trying to rush now because of time. We also look at the risk score of chronicity. By the time you use the Kill Start Back screening tool, you'll be able to know, since we said if the patient scores above 4, it means the patient has a high risk, and therefore it requires early multidimensional therapy or interventions. So all these are issues I want us to look at for, and then we should be able to see how we make use of them. I'm happy that the host, facilitators in this program are already providing us with some of these tools. I saw in the chat box, Dr. Jibril Samani has given us the one of the questionnaires already. The ODI is there, so please, we can feel free to download. Those were used in the presentation tool. If we can pick them out and then print, it's going to help. So in general, the summary of the finding today is that Madam Amina has a moderate pain and moderate disability. Of course, she's got some presence of fear avoidance behavior and mild anxiety. Then she has a high risk of developing chronicity of her pain if we don't intervene. So that makes our intervention very, very important. This is what the whole presentation is all about. How do we integrate our outcome measures in assessment? It tells you that when you have most of these assessment forms, it's going to guide you on what you should be doing for your patient. Because when you see the patient, sometimes your head goes blank. You wouldn't know what to do. What do you assess in this patient? How do you assess something? So, but when you have all these outcome measures in your front, it tells you this, from that to this. So we have 5 domains: pain intensity, functional disability. We talk about the psychological factors. Then we talk about catastrophizing, of course, under pain psychology. And then we talk about preventive, those domains that we use to prevent this problem from recurring or coming back. At the end of this, we use a multi-dimension or the biopsychosocial approach to now see how to intervene to the patient. We know that our management plan must include both manual therapy and education. You educate the patient on changing their understanding of what this pain is like. Let them know that the pain is not necessarily from the pathology, and your pain could come from different things. If you tell me now, somebody who lost 10 million naira, is there anywhere that they have cut in his body? Will you see a structure where the pathology is showing? But the amount of pain in your heart, you know the pain you are going through. I mean, just imagine losing 10 million naira in Nigeria now. That is a huge trouble, So you will realize that it is not necessary that there is a pathology, but the pain is real, and we need to treat the pain. The fact that you cannot see a pathology relating to a pain does not mean a pain does not exist. So we must put that into perspective. Of course, exercises, manual therapy are things we should do. And our functional goals should be, we want to improve the patient in terms of sitting, standing, walking, and then tolerance in activity. The patient should be able to endure more of this activity. Social intervention should be reassuring the patient you are going to get well. This is the normal scenario. This is how it comes. You are not the only person. This is how almost every patient with back pain comes. So just keep calm. You will it will go over this. So that reassurance is very important. And of course, graded activity. You let them know that you don't want you to remain docile or dormant, they need to be doing what we call the active rest. So the individual must be able to do activities. So we call it active rest. Eventually, we'll create the preventive strategy so that we don't go back to where the problem is coming from. So these are what we say you use multidisciplinary approach than just one singular approach. In trying to treat your patient, don't forget that you must keep reassessing the strategy and the patient generally. You treat your patient after 2 to 4 weeks, you should reassess the patient and be sure the treatment you are giving, is it beneficial? Is the patient responding to treatment or not? If the patient, like your MPRS, cannot detect 2-point difference, then you should know that that thing is not responding. And then if your ODI also cannot detect any changes greater than 10%, you know there is a problem. Of course, the patient satisfaction should be able to see that you have changed in 2 to 3 points. And of course, we should see that your fare have reduced significantly. So all these are issues we want to take into cognizance during the use of outcome measures to treat individual with back pain. At this juncture, as all our children are tired, I had a baby already calling the mother to leave this presentation. So we are going to be drawing the curtain at this point. I want to thank everybody very well. I thank you all for participating. And I want to call your attention to please complete the workshop evaluation form and the certificate of completion so that you can get it as soon as the presentation is ended. So thank you once again for your time. So the floor is open for every question and answers. Thank you.
Thank you so much.
Thank you very much, sir.
Thank you very much.
Oh, excuse me, sir.
Yes.
Thank you, sir.
So when you were talking about scoliosis, you mentioned that scoliosis cannot be managed by physiotherapy. I mean, conservatively.
Please, the mother with the baby, we can let her go and take care of her baby. Yes. Okay, Esther, you were saying something.
Yes, you said that structural scoliosis cannot be managed conservatively.
Yes.
But isn't there a part to... Yes, sir. But isn't there a part... Well, in the different stages, but around the early stages, isn't there a part to play for physiotherapy to be able to slow down the progression, especially in idiopathic cases?
Well, you see, structural scoliosis usually develop at the embryogenic stage. And it comes with fusion already of the spine. Okay? So already the spine is fused even before the patient will get to the position of meeting you. So you find out that in any position you move or you bend or you do the patient, that curvature is there, it does not go. So there's nothing you could do conservatively to stretch the patient or open up the joint that is fused. And that's why they say the structural scoliosis can only be managed surgically. So after surgery, the patient can now continue their physical therapy.
Okay, so when we receive referrals for structural, we should refer back.
Actually, you are not supposed to be the physiotherapists are not likely to be the one that will detect or diagnose the structural scoliosis at first. But if it does happen that you're seeing the patient with structural scoliosis for the first time, and perhaps maybe the patient did not come through the GOPD, or maybe the GOPD physician was not able to detect that it's structural until the patient gets to you, all you need to do is to refer back to the orthopedic surgeon.
Okay. But yes, sometimes they refer them for physiotherapy pre-surgery to just see.
Most often they just don't want to show that there's nothing they can do.
Oh, wow.
So they throw you the patient so that the patient thinks it's you that don't know what to do.
Okay.
That's true.
What is the role of spinal
So structural scoliosis is a congenital skeletal abnormality.
Sorry, Mr. Emeka, before you speak, somebody is trying to speak from far away.
Sorry, sir. Sorry, sir.
Okay. Yes. Woody, your Bluetooth is making you far away. Woody, come closer.
What is the place of spinal jacket or spinal support?
Spinal jacket.
Okay.
Yes, it's just like your maneuver jacket. The essence of your maneuver jacket is for two things. Number one, after correction, and you want to maintain the position, maneuver jacket will help you do that. Number two, if it's a growing spine and you feel that if you're able to stop the spine from growing, the scoliosis might not get worsened. That's when it will be useful. But as long as the causative factor of the scoliosis is still there, then there's no way that maneuver jacket will help the patient because it's going to bend the spine into that situation whenever it's removed.
Thank you, sir. I'm clear, sir. Thank you, sir.
All right. So, Ilaba, Emeka.
No, sir, my question is so the structural scoliosis, is it synonymous with a congenital skeletal or congenital scoliosis?
Yes, that is it. Because it usually comes from that embryogenic stage. So it is.
All right.
Yes.
All right, so I'm glad. Thank you.
Thank you. Yes, any other question? I saw Abdullah, you want to say something? Suleiman? Okay. In the absence of any other question or clarifications, okay, Dayo.
Yeah.
Yes, go ahead.
Yes, sir. Clinically, at what pain intensity is good for discharge? To discharge appreciate to discharge a patient.
Sorry, I didn't get the question. You said what pain intensity is what?
Thank you.
I didn't get the question, Dayo. I only had you talk about at what pain intensity. What do you want to ask about? Sorry. Did anybody get the question
He
that I
said,
was trying to? Yes.
He asked that at what pain intensity can a patient be discharged from? Like, at what pain intensity will you say this patient is ready to be discharged?
Okay. Yes, like I mentioned earlier in the presentation, patients usually come to the clinic due to the pain. But we as physiotherapists, we know that it is not the pain that is most important. Most time our patient is their functionality that we should be concerned about. Now, a patient, most time after surgery, that's what they will go because of the pain. That's the reason they go for surgery. Now, a patient had surgery but can no longer move. Will you call that a successful surgery? A patient who walked to the theater himself, now after theater, but there is no pain and he cannot do any activity. Do you say call that a successful surgery?
No.
No, because the patient will not even forgive himself. He will have preferred that I'm walking before, which one is this one now that I'm confined to wheelchair, you know? So these are the question you were asking is supposed to be based on your clinical reasoning as well as your what do you call your discretion. So if you finish your patient presented with pain and that pain there was lack of activity and so many things, and now you've been able to take care of the pain, and then but you now realize that the functionality of this patient is not good. I think you should still keep the patient and work on the function more. All right. But if you think you have taken care of the pain and the patient feel I'm happy, we can go. In fact, sometimes patient can now tell you, I can walk from here to this place. I think my pain just comes much more, or it's marking you pain 3 or pain 2. Your patient can still go because there are times when you keep patient too much, they still feel they are sick. That's why you are keeping them. So you have to look based on your description and your clinical reasoning to know when to discharge your patient. Okay? You also look at their psychology, and that's why we're evaluating for all these domains. You don't just look at only pain. That's my point, Dayo. I hope you get it. You get the point.
Yes, sir. I
All right.
understand. Thank you.
Okay. So thank you everybody. Dr. Jibril Samani, any comments you want
Thank
to
you
tell?
so much, Professor, for the
Thank
in-depth
you very much,
presentation.
sir.
It's just to commend you and then also inform the audience that next week is going to be a follow-up presentation where we will be looking at the special tests regarding low back pain assessment, and it's going to be hands-on for physical attendance, and those that cannot attend physically can still join virtually. It will be streamed live. So see you next week. Bye-bye.
All right. Thank you very much. Have a wonderful evening all.
Thank you, sir.
Yeah.
Thank you very much, sir.